Just let me know when we are live.
Live right now.
Assalamu alaikum. Good evening, everybody. Good morning, good afternoon for our colleagues in other time zones. I would like to thank the organizers for this excellent program that they have organized for the last few days, and ahead of us few days. I'm sure all of us are benefiting from this program. On behalf of SSPD, I would like to welcome you all to day 4 of this conference. Today will be Hello. Assalamu alaikum. Good evening, everybody. My name is Ali Al-Ahmari, pediatric hematologist, oncologist. I would like to thank the organizers, both the scientific and organizing committee, for this nice program. Today we come to day 4 of the Saudi Annual Hematology Congress. And today we will be having an exciting program ahead of us. This Congress well attended, and also we had so far excellent speakers. Sure today we will enjoy our program with distinguished expert speakers in their field. Also, the field today we will be discussing is very hot area now in hematology. Without further delay, I would like to thank you all, and I wish you a fruitful meeting today and in the coming few days. Today and tomorrow we will be discuss topics related to innovations in hematology. Without further delay, I will pass the mic to my colleague, Dr. Sayyid Usman, is a consultant hematologist and stem cell transplanter at King Faisal Specialist Hospital. Dr. Usman.
Thank you very much, Dr. Ali, the organizers, the speakers. Assalamu alaikum, good evening. These are obviously exciting times for innovative therapies in hematology, especially cell and gene therapy. I'm just going to give a brief overview, if I can, of what's been happening at King Faisal Specialist Hospital and Research Center over the last few years, as we try to maintain the institution's place at what we hope is the forefront in the region. If I can have the next slide, please. Right, I don't know if you can see my slides. No. Okay. What I'm going to go through anyway, hopefully the organizers could show just one timeline that I was hoping to show. I don't know, Dr. Ali, it can be seen, but essentially, the King Faisal Hospital has been keen to maintain its place. The administration at King Faisal Specialist Hospital at the highest level has been very driven to provide us with what we need so that we can provide cutting-edge therapies to our patients, and so that patients have access to cellular therapies and gene therapies. Our colleague over here, Dr. Ali Al-Ahmari, has been instrumental, and we're grateful to him for his efforts in bringing CAR T-cell to King Faisal Specialist Hospital. We have infused a number of patients. Our own head of department, Dr. Zahrani, has been the PI for the hemophilia gene therapy project and trial at our institution. Obviously, slightly uncertain times with what's happened, but I'm sure we'll hear more about that. We've infused a number of patients with commercial products, and though we would have liked to have done it earlier, we're sometimes limited by the rollout of how institutions want to take CAR T cells and advanced therapies across the globe. However, we do look forward to more therapies and more opportunities to provide these treatments to patients. We're very grateful to our experts, many of whom we know, who have visited us in the past. And inshallah, once Corona's over, we can visit each other again. We hope you find these lectures beneficial. Again, I'd like to thank the speakers, Dr. Ali, and the organizers for what's a very stimulating program. And with that, back to you, Dr. Ali.
Thank you, Dr. Said, for this excellent overview. And without further delay, we'd like to come to the first sessions. And in these sessions, we will be having three very exciting presentations. The first presentation will be delivered by Dr. Arkin. Dr. Arkin is the David Nathan Distinguished Professor of Pediatrics at Harvard Medical School and Howard Hughes Medical Institute investigator at Boston Children's Hospital. He previously served as chairman of Department of Pediatric Oncology at the Dana-Farber Cancer Institute, and he received numerous awards. Dr. Arkin, he is going to present emerging gene therapy for hemoglobinopathies. Dr. Arkin.
Thank you. I hope you can hear me. You can hear?
Yes. Yes.
Good. Okay, thank you. So I will first like to thank the organizers for this opportunity to present. And what I would like to do is first give some of the scientific background and then give you the latest on what's happening in the field of gene therapy and gene editing for the hemoglobinopathies. I probably don't need to remind this audience that the hemoglobinopathies are a global disease and global burden. And this comes from a review by David Weatherall of sort of the distribution of hemoglobinopathies, and reminds us that there are hundreds of thousands of individuals affected with these disorders worldwide. And I'm speaking particularly of beta thalassemia and sickle cell disease, more than 300,000 new births a year. And it's also anticipated that the number of individuals affected will increase over time, particularly if infectious disease comes under control, so that children who are born with these disorders will actually survive to adulthood. So the two disorders are obviously sickle cell disease and beta thalassemia. Beta thalassemia is probably more prevalent in the Saudi Arabian area and involves many mutations which affect beta globin synthesis and therefore formation of adult hemoglobin. In the case of sickle cell disease, there's a point mutation in amino acid 6, which affects the protein such that the protein will polymerize in so-called sickle, and that obviously affects the adult beta globin gene as well. At the top is the structure of the globin locus, the beta locus in man on chromosome 11. Just want to emphasize that the genes are ordered embryonic, fetal, and adult on the chromosome the way they're expressed. Fetal hemoglobin was described quite early and recognized as a modifier of severity for both sickle cell disease and thalassemia. The data here pertains particularly to sickle cell disease, but in 1948, a pediatrician, Janet Watson, described that newborns that are destined to have sickle cell disease are not affected phenotypically at birth, or in the first few months. And she hypothesized that was due to the expression and presence of fetal hemoglobin, which is protective, and that's correct. And in a study of sickle cell patients, a natural history study in the United States, survival was higher in patients with higher levels of fetal hemoglobin. And the same can be replicated in individuals with beta thalassemia. So the problem that we've addressed in the scientific basis of a lot of the recent excitement in the field is to try to understand what regulates this switch from gamma, the fetal genes. There are two fetal genes in the human, to beta, the adult gene, which occurs around the time of birth. And in adults, we have about 1% fetal hemoglobin, which is restricted to a small population of cells called F cells. And the consensus in the field has been that if we could increase this 1% level to something like 20% of fetal hemoglobin, but distribute it more or less equally among cells, that would be very protective in sickle cell disease and beneficial in beta thalassemia. And if one increased that level even slightly higher, it would essentially be curative in patients. One could reactivate the silent fetal gene to essentially replace a defective or missing adult beta chain. And really the crux of the problem has been to try to understand how to do this, and really what controls this switch. This has been a problem studied for many, many years, and this is a timeline of studies in this area, starting in the 1940s going to the present. And I won't go through this at all, but I just want to emphasize really the longstanding interest in the field and really the attention that's been devoted to this topic by many investigators over many years. The breakthrough in the field in terms of understanding this phenomenon, the switch, occurred in 2007, 2008, with the introduction of genome-wide association studies, which are depicted here, in which one measures the amount of fetal hemoglobin, the level in individuals, and tries to correlate that with conditions in the genome. And the studies are summarized here, one from Swile Thien in the UK, and then a study from Antonio Cao and others in Sardinia, identified 3 loci associated with increased fetal hemoglobin. These loci were assigned to short armor chromosome 11, which is the globin cluster, which is not surprising. The MIB locus on the long arm of chromosome 6, and there was other evidence suggesting that as a region that it could affect hemoglobin F production. That probably affects cellular differentiation. But the new finding was the gene BCL11A on short arm of chromosome 2. And if one sums the contribution of these three loci to the entire genetic variation in the hemoglobin F levels in populations, it's at least 50%, which is, by these kinds of genome-wide association studies, really an astounding genetic contribution. We focused on BCL11A for many reasons, particularly that it was a new factor and could have a direct role in this switch process. Now, the challenge in genome-wide association is going from the entire genome of 3 billion base pairs to something of several base pairs or several hundred base pairs to understand the relevant target sequences and perhaps have some consequences or implications for disease. And in my group over the last really decade, we've gone from the genome-wide association right down to specific sequences that are now being used for gene editing to reactivate fetal hemoglobin. And this involved a series of studies to validate a role for BCL11A in the switching process. We discovered an enhancer within the gene that I'll come to, that it's a particularly favorable target for gene editing. And then we've done a number of the preclinical kinds of studies that are required before clinical translation. Now, an important question at the outset is how important is BCL11A as a single factor? There could be many, many factors involved in hemoglobin F regulation, and how important is this one factor? And perhaps the most important experiment to get at this is shown here, in which we used sickle cell engineered mice, in which the mouse genes are removed and human genes are put in the mice, and in this case, sickle adult genes, so the mice have sickle cell disease. And we cross these mice with a conditional mutation for BCL11A. And in this case, removed BCL11A in only the erythroid lineage to prevent any effects elsewhere in the mouse. And we asked, could removing BCL11A in these mice reactivate fetal hemoglobin and perhaps ameliorate the disease in the sickle mice? And the result was actually more impressive than we had imagined. And I think you can see that in the blood smear at the top. In the middle is the sickle mouse blood smear. And on the left is the control mice. And on the right, the mice have BCL11A knocked out in the erythroid cells. And essentially, the hematology is normal in these mice. They express fetal hemoglobin to a total level of about 25%. And it's distributed really widely by FACS, as you can see, in more than 85% of the cells. This one experiment showed that removal of BCL11A in the erythroid lineage is sufficient to abolish sickle cell disease phenotype through reactivation of hemoglobin F. This level of 25% is sort of where one would want the threshold to be to ameliorate disease. It's a little hard to compare this to what it would be in a human individual, because these mice have engineered genes and they're not quite arranged the normal way, but at least it shows the single factor is really a very potent factor in keeping fetal hemoglobin off. And this is really the basis of almost all work going on now in terms of reactivating fetal hemoglobin for therapy. So really the crux of the problem is simply shown here. The locus control region, which is the major enhancer for the entire beta globin cluster, has to interact with the downstream genes in order to turn them on, either in the fetal liver stage or the adult stage. In the fetal liver stage, the gamma genes are on, these are the fetal genes, and in the adult stage, the beta gene is on. And the repressors that keep the gamma genes off are BCL11A and another factor called LRF, which I don't really have time to go into in any detail, but it's roughly an equivalent kind of repressor, although we think BCL11A is the major physiological repressor for the switch. So how does BCL11A keep the gamma genes off? This summarizes some of our recent work. The BCL11A is a DNA binding protein, and it recognizes the sequence TGA-CCA. The sequence is duplicated in the gamma globin promoters, but BCL11A only interacts with the distal one of these two, and it recruits the complex called NERD, which is a repressive complex. And what that does is represses the locus and keeps it closed such the gene is not expressed, and the LCR interacts with the downstream beta globin gene. So what drives the expression of gamma in the fetal stage? Well, in the fetal stage, there's an activator protein called NFY, and it binds a sequence called the cat box, CCAAT, and it just so happens the TGACC binding site for BCL11A, which is duplicated, is overlapping or abutted to a cat box site that's also duplicated. But what's very interesting is that NFY only interacts with the downstream cat box, whereas BCL11A interacts with the upstream or the more distal site.
Yes, I can.
And what happens when BCL11A comes on at the adult stage it basically evicts NFY and bumps it out of the promoter, leading to repression. And we think this is the major mechanism for the switch. And what's quite remarkable is there are only 21 base pairs separating these two sites between where BCL11A and NFY bind. And really, this is the site at which competition between these two factors really determines the switch. So BCL11A really has two roles. One is direct repression, that is, it binds the promoter and physically obstructs and evicts the NFY protein. And in addition, it recruits the NERD complex, which has a number of enzymatic functions which contribute to repression. And this is a more refined view of the promoter. This is the gamma globin promoter. BCL11A binds to this region where there's distal TGA-CCA, and NFY binds at the proximal site. They compete with one another. And the other repressor, LRF, binds around -200, and both of these proteins recruit the NERD complex. In addition, I should mention that the binding sites of both BCL11A and LRF are sites of rare mutation, not common mutation, but rare mutation in classical hereditary persistence of fetal hemoglobin, situations in which the level of hemoglobin in adults is quite elevated, 10 to as much as even 20 or 30%. And so BCL11A is really quite remarkable in that it binds the cis element that's mutated in HPFH, and so it also is involved in these rare syndromes. Now, I had mentioned in really where is the common variation that's detected in GWAS studies, and to get to that, we asked where were the most highly correlated SNPs or associations within the BCL11A locus. They occur within an intron of the gene, so there's no genetic variation in the protein coding region. And within this large intron 2, there are 3 DNase hypersensitive sites over about 10 kilobases, which represent really an erythroid-specific enhancer within the BCL11A gene. And we've shown in other studies this enhancer is required for expression of BCL11A in the erythroid lineage, but not in other cell contexts. And therefore, this represents really a unique genetic region for manipulation, because if one knocks this region out, one would knock out erythroid expression of BCL11A, but not affect BCL11A in any other tissues. We use CRISPR-Cas9 to really pepper this enhancer with mutations to see if there was a particular region of the enhancer that might be more important than the whole enhancer itself. And what we determined was a very small region next to a GATA sequence, a binding site for the GATA1 protein, within this hypersensitive site in the middle called +58. And that's really an Achilles heel for the enhancer. So if one makes a single cut with either a zinc finger editing or CRISPR-Cas9, it approximates deletion of the enhancer to about, it reduces the enhancer function maybe 2/3 or 3/4. So BCL11A levels fall and it relieves repression. And this is really the focus of gene therapy and gene editing studies right now, which I'll come to. So BCL11A is quite unique. It really genetics converges on both common genetic variation, which affects the enhancer, and rare genetic variation, which affects where BCL11A acts in the gamma promoters. And this summarizes really the genetic studies of BCL11A, that there's common variation, which will affect very low levels of hemoglobin F, such that one goes from 1% to 2 or 3% in the high allele. If one deletes the BCL11A enhancer, one ablates BCL11A expression, and hemoglobin F would be very high. And in therapeutic targeting of this, one can approximate this, although one still has a little BCL11A expression. So this is the basis of the current genetic studies. So how can we leverage this for therapy in the last few minutes? Well, we now believe that the genetic approach has been validated, as I'll summarize in the next couple of slides. So the goal then for therapeutics based on BCL11A is to reactivate fetal hemoglobin through inhibiting either the function of BCL11A or removing it. And this could be achieved by a number of ways, as shown below: knocking out the gene, knocking down expression, editing the enhancer, etc. And I'll just summarize sort of where the approaches are right now. Knocking the gene out entirely is probably too toxic for hematopoietic stem cells. You also ablate function in B cells if you do this in stem cells. But another approach is a knockdown, which are ongoing studies from Children's Hospital in Boston. One could edit the enhancer, and there are ongoing CRISPR-Cas9 editing trials. And the third possibility is mutating the binding site for BCL11A in the gamma promoter, and there are preclinical studies under development in that regard as well. So what is the genetic therapy of these disorders? It's to remove hematopoietic stem and progenitor cells, modify them ex vivo, either with a lentivirus or with gene editing machinery, take those modified cells and reintroduce them into a preconditioned patient. And obviously there are many, many parameters I don't have time to discuss that are important, which are the fraction of cells modified, the efficiency of the modification, off-target effects, cell dose, preconditioning, many, many topics which we don't have time to go into. So the targets of genetic therapy of the hemoglobin disorders are really summarized here now. The beta globin gene, you could imagine in the case of either sickle or in thalassemia, repairing the gene with CRISPR-Cas9 by homology-directed repair, correcting the gene. That's not in clinical trial now because the efficiency is still not quite good enough. What one can knock down the mRNA with shRNA, one can modify the enhancer, mutate the enhancer, or the binding site. Or additionally, one can use the newer approach of base editing, which is suitable to mutate the binding site for BCL11A within the gamma promoters. And all of these are being entertained now. As many of you are probably aware, at the end of December, two small clinical trials were reported, one for Boston Children's Hospital using shRNA in an erythroid-specific manner to reduce BCL11A in the case of sickle cell disease, and CRISPR-Cas9 by Vertex and CRISPR Therapeutics using editing of the BCL11A enhancer in both sickle cell disease and thalassemia. And both of these studies showed rather dramatic results. Here's the children's study, a patient with sickle cell disease, the first one shown on the bottom right, who's now more than 2.5 years out from his therapy. After therapy, he had no sickle cells. He's been clinically well, and his F cells are more than 75%, with hemoglobin F at about 25% total. He's been asymptomatic and well, and additional patients have been involved in this trial. And what's most remarkable is the outcome, clinical outcome is the same in all patients. They're well, they have 75% fetal cells and have enough fetal hemoglobin per cell, per F cell, to ablate sickling. In the case of the gene editing trial by Vertex CRISPR Therapeutics, they attacked the enhancer precisely with a guide RNA that we had described in 2015 and used that in both sickle and thalassemia. Here's a sickle cell patient who had essentially 100% F cells and a hemoglobin F of 46% and is clinically well. And a patient with beta 0 thalassemia had a similar kind of outcome. So I now believe that the genetic approaches are validated. And the question then is, how can we scale these to larger patient numbers? It's highly resource intensive to perform ex vivo gene editing or therapy. So the thoughts are that one needs to devise improved non-ablative preconditioning methods, or really invent new methods for in vivo gene therapy. And these are both challenging exercises, but are being considered in many places. And this summarizes the clinical trials in the gene therapy area for the hemoglobin disorders. And here I've just added also Bluebird with a lentiviral so-called beta addition, where one adds a globin gene. One doesn't aim to increase fetal hemoglobin. And that's approved in Europe, but as many of you also probably realize, there's been a recent hold on these trials because of 2 patients with sickle cell disease who developed cancer or myeloproliferative disease. And the issue under study now is whether this relates to the lentivirus, to interaction of the sickle environment with lentiviruses, with preconditioning, or is it genetics or bad luck? And I don't think we know the answer at this point. So the take-home messages that I want to leave you with is the mechanism of switching is now coming under focus and is pretty well understood, and BCL11A is a central component. It's a valid target for therapy of the hemoglobin disorders. The clinical trials have moved along very rapidly and show positive results and are likely to be approved, although adverse events need to be watched very, very carefully to evaluate risks and benefits. And I think the future is developing on-target small molecules drug therapy to really impact these disorders globally, and that's really a separate topic. So I'll stop at this point and thank you very much for the opportunity to present, and I'll return for the question and answer session later.
So thank you very much for inviting me to speak at this meeting. And I'm going to talk about gene therapy in haemophilia.
Hello. Hello.
Hello.
John, welcome. Just 1 minute. You would like to, Dr. John Passy is Professor of Hemostasis and Thrombosis at the Royal London Hospital. Also, his Barts and London School of Medicine and Dentistry and Hemophilia Center Director. His research interests cover many aspects of inherited and acquired bleeding and clotting disorders, especially in new bioengineered and novel therapies for hemophilia, including gene therapy and RNA interference technology. Without further ado, Dr. John is going to talk today about current and future gene therapy in hemophilia. Dr. John.
Thank you very much. And sorry about the slight hiccup with the slides here. So thank you very much again for asking me to talk about hemophilia and gene therapy. When we think about treatment of hemophilia today, we recognize it's very good treatment, but it is a treatment that comes with a significant treatment burden. If we're going to treat patients effectively with factor concentrates, we have to give injections every alternate day. With new treatments, such as emicizumab, the treatments might only be once a week or once a fortnight, but that's still quite a significant burden for patients to think about. Hence, for many, many years, gene therapy for hemophilia has been regarded as the holy grail, the treatment that could really offer a complete change and potentially a cure for the disease. So why is hemophilia such an ideal target for gene therapy? Well, this slide lists some of the reasons. It's a single gene disorder where there is a clear cause and effect relationship. And as I've just covered on the previous slides, treatment is demanding at very best, with frequent injections for extended half-life therapies, and even the newer treatments requiring at least once weekly intravenous or subcutaneous administration. But from a scientific point of view, perhaps more importantly, there is a very wide therapeutic window. We only need a low level of expression to dramatically improve outcome. That, at the end of the day, is the basis of prophylaxis that we use at the moment, to get a target above 1% to stop spontaneous bleeding. And anything above that we would welcome, obviously up to a point because there is a thrombosis risk, but we never really thought we would have to consider those sort of levels in the past. So very wide therapeutic window. In terms of assessing the treatment, it's easy. In clinical terms, patients will stop bleeding, their treatment requirement will drop, and in laboratory terms, it's similarly straightforward in that we can measure factor levels. So when we think about haemophilia therapy, we base everything essentially on raising the factor level. If we can raise the factor level, we will reduce the bleeding rate. Reducing the bleeding rate reduces the treatment requirement. Reducing the treatment requirement reduces the burden, and these in turn reduce anxiety and so improve quality of life for our patients. So how can we do gene therapy for haemophilia? Well, the ideal is to be able to give a single intravenous injection that transduces cells in vivo. That would be our ideal approach. We have had in the past historic systems that have used an ex vivo approach, much like the sickle cell approach, where tissues are removed, modified ex vivo, and then transplanted back. Over the years, lots of different viruses, vectors, and systems have been used, with retroviruses being used, with systems using different viruses to transduce cells, but we've now focused essentially on the in vivo approach. And we have used, for the in vivo approach, essentially small viruses, the adeno-associated virus, and this has become the favored approach. And this is what I will talk about most in this talk. One thing that I think is worth bearing in mind, though, is that there has been a lot of excitement, a lot of hope and expectation about haemophilia gene therapy. And we see here something called the Gartner hype cycle, which is about the introduction of technologies and the actual plateau of productivity, and how things change in between, with inflated expectations, disillusionment because of technical failures, and then a slope of enlightenment as we learn what the issues are. The technological trigger for haemophilia gene therapy was in the 1990s, and the peak of inflated expectations was probably around the 2000s, and hence the trough of disillusionment in the mid-2000s. And from about 2005 to 2011, people really began to understand what the scientific issues and technical issues in terms of gene therapy were behind the problems that we were facing. We hope we are today on that plateau of productivity, but I think it's still important to bear in mind that we may be still having some inflated expectations about what gene therapy can achieve. The other thing to mention about adeno-associated virus, which I've mentioned is now the favored approach, is that the genes that we transfer through AAV do not integrate into the host genome. The lentiviruses and retroviruses will integrate. Adenoviruses, and particularly in our case, adeno-associated viruses, remain episomal. This means that the expression is deemed to be moderately stable because the episomes may be eliminated from cells upon cell division or anything that could stress the cell. So this is something that's important and may account for some of the features that we see in terms of gene therapy in the future. So what do we know about AAV, which, as I mentioned, has become the favored approach? Why is it favored? Well, it's a very simple virus that doesn't cause any pathology in man. It has two genes which can be replaced by our chosen gene cassette with inverted terminal repeats on either side. There are also many, many different types of AAV around, different serotypes, but the ones that are used in gene therapy tend to cluster in two groups. There's a group based around AAV2 and AAV8 with some work on AAV6 and 10. And there's another group of work being done on AAV5, which, although an AAV, is rather distantly related to the other clusters of AAV serotypes and more closely related to the primordial AAV, AAV-Eve. Aside from having the variations and different options for AAV, we can also modify the expression cassette to try and enhance what we want to achieve. Now, clearly, our cDNA in the main will be factor 8 or factor 9, but we can use a wild type, or we can use an enhanced gene structure, such as the Padua for factor 9, where the Padua variant, a single nucleotide change in the factor 9 gene, has 6 to 8 times the activity of the equivalent wild type protein. Both factor 8 and factor 9 are codon optimized, and additional enhancing sequences can be added. We can also look at modifying the 5' end with promoters and different regulatory sequences, and similarly the 3' non-coding elements. This is much more possible for factor 9 than factor 8. And the reason it's not possible for factor 8 is that factor 8 is such a big gene in mRNA terms to get it into an AAV that we don't have any room to make such amendments. So factor 9s can be much more altered and the cassette designed more specifically. Today, though, gene therapy has become, for haemophilia, a very crowded field. Rather than having 1 or 2 different programs out there, one for haemophilia A, say a couple for haemophilia B, we now have many, many programs. And I'm going to talk about just a handful of these selected programs, but it's fair to say that this is increasingly crowded now as a technical and scientific area of research. The real issue, though, with gene therapy is that with 2 of the pivotal earlier studies that were published in the end of 2017 in the New England Journal, the question has arisen, is gene therapy finally here for haemophilia? And the fact that that was probably added to by the editorial suggesting that a cure for haemophilia was actually within reach. These 2 studies represented one on haemophilia B and one on haemophilia A, and I'll talk about them as we go through. But this result set was certainly very important in changing our perception of haemophilia gene therapy and what it could or could not potentially achieve. Suffice to say, for all the studies I'm going to talk about going forward, in terms of clinical impact, they all look much the same. This data is actually data from a factor 8 program using an AAV5 with a B domain deleted factor 8 from biomarin called BMN270. And what we can see here in 2 different cohorts is pre-infusion bleed rates being sort of high, and then as soon as they have the gene therapy, it plummets and becomes very low. This is because as soon as you express factor 8 or factor 9 at levels that are probably more than about 3 or 4%, the bleed rates drop dramatically, as does the requirement for exogenous therapy to be given. So I'm not really going to talk about efficacy much in this program because they all look the same. Pretty much all the data that you would present in terms of bleed rates in the programs looks like this. Now, let's have a look at these different programs, and I'm going to split them up into haemophilia A and haemophilia B and note some of the differences between the 2 and why haemophilia A might be biologically quite different from haemophilia B, apart from simply being a different gene. This slide shows the products in development, or the ones that have been terminated in the haemophilia B space. And as you can see, there are really quite a lot. I'm going to talk about 3 of them, which are the Unicure program, the Pfizer Spark program, and also just touch on the data that we have from these. So the first of the important programs is the SPARK data. This is a bioengineered AAV capsid containing the Padua variant. As you remember, the Padua variant has the increased activity of factor IX compared to the wild type. This is the data that was originally published in 2017. And the reason that this data stood out was because the level of expression of factor IX was so much higher than previous programs, which is expressed in the range of 2 to 6%. And here we were seeing means of around about 30% factor IX at a year. That was a huge difference to what had been achieved before. And as we can see, we have a mean of around 30. What's happened over the years? Because this program is now more than 4 years out. And what we can see is that the factor IX levels have remained essentially pretty stable over this period, as shown in this box and whisker plot. And as you can also see, the ABRs just above the graph have all remained similarly low. The other program I'm going to talk about is the Unicure program, which is based on an AAV5 serotype of AAV with both a wild type and a Padua variant factor IX. The top panel here shows the original human factor IX wild type in AAV5 for patients that have now been followed out to 5 years. This data was just presented recently at ASH. And what you can see is, though the levels are not that high, they are remarkably stable. The bottom panel shows the same AAV, the same cassette, with one single exception, that this contains the Padua variant. This is only 3 patients. This was the original phase 2b, but what you can see is that the levels are dramatically higher, 6-fold higher in many cases than the wild type factor IX. This Padua variant has gone forward into a phase 3 program, which has similarly just reported its week 26 data at the ASH meeting. And the important thing here is that this has demonstrated very similar results. That is a mean factor IX at week 26 of around 36%. And we can see that 1 or 2 patients that have gone out to 12 months or indeed 18 months show similarly stable levels. So together, we're optimistic about the future for haemophilia B, showing good levels that are stable for up to 5 years or beyond from the data that is available. So what about haemophilia A? I've already alluded to the fact that this may be somewhat different, and indeed it probably is. The number of programs for haemophilia A are again manifold, some in preclinical, some in early phase 1. But the 3 that I'm going to talk about are the BioMarin program, Sangamo Pfizer, and also I'm going to talk about the SPARK Roche program. This is the data at 4 years from the BioMarin BMN 270 study. As you remember, I mentioned this when I showed the efficacy data earlier, and this is an AAV5 containing a B-domain deleted factor VIII. The big difference here that you can see, apart from the higher levels at year 1, is that there is a shallow and continuous decline as we go out further. We didn't see this in haemophilia B. So in haemophilia A, there appears to be a decline slowly over years. But what we still see at 4 years, where the levels are mean of around 24 or median of 16, is still very effective bleed control with bleed rates of a median of 0. So even though they're declining, they're still providing massive clinical impact. This product, which is called valoctocogene roxaparvovec, has now gone into a phase 3 study, and this early phase 3 data was presented at the JP Morgan Investors Conference and shows that at 6 months, in 134 patients, 112 in the rollover and 70 and a smaller number in a direct analysis population, we see that again there is good expression of factor VIII, but a very wide range of levels being expressed. And if we look at the panel on the right, which takes patients out to approximately 2 years, we can see that there is again some evidence of the decline, but the decline in this population is shallower than in the original phase 1/2 program. So what about other programs? This is SB525, which is the Sangamo program using an AAV6. This is the highest dose cohort. And again, we see good expression, but we also see suggestions of a decline as we go towards 12 months. And if we look at the individual plots, we can again clearly see that some patients are declining in factor 8 level. Finally, the SPARK program. This data is presented in a much more scattered manner and has been through the way it's been presented at various meetings. So it's a little bit more difficult to judge what's going on. Also because there are different programs of using steroids proactively, retrospectively or not. And so it's harder to see what's happening. But there is a suggestion also here, there may be something of a decline, although that this is, others might suggest that this is more stable. So haemophilia B and haemophilia A look somewhat different in terms of stability. But what can we say about gene therapy overall? Well, in terms of efficacy, it's very potent. If you express the transgene, you vastly reduce ABR and treatment reduction. There are liver function abnormalities and transient elevations of ALT that are seen across all programs, and I'll touch on that in a moment. And there might be a decline of transgene activity. So what are the recurring questions that we tend to see in gene therapy? Serotypes for AAV are very important because this has potentially a big impact on redosing and also eligibility. Patients are largely excluded if they have pre-existing antibodies. We also don't know whether the AAV serotype affects the immune response and it's a cause of the transaminitis or not. As I've mentioned, transaminitis is very common in gene therapy. With AAV, we think that one potential mechanism is a CTL response to transfected cells, but another may be the fact that we could get an unfolded protein response. So when we use steroids, are we using it as an immunosuppressant, or are we potentially using it as an anti-inflammatory agent to reduce that unfolded protein impact? We also, across all these programs, I think you will see that we've seen considerable variability in the level of factor 8 and factor 9. And are we changing our attitudes by striving to get normal levels in all our patients? How long is adequate for the treatment of with gene therapy? Haemophilia A and B are probably not the same. Haemophilia B looks more stable. Haemophilia A maybe has a decline, but how long is that that durability does it need to be to become clinically important? There are possible different explanations for decline, including failure of transgene stabilization in the episomes, transgene silencing, as I've mentioned, protein synthesis triggering ER stress and an unfolded protein response, or a persistent immune response. And we could think about the gene copy number going down or the RNA from the transgene changing. The problem is they all look very similar. And even if we did serial liver biopsies, we probably wouldn't be able to pick a difference between these different mechanisms. Finally, these AAV treatments can only be used in adults because in children with the liver growing, cells turning over, liver volumes changing, plasma volumes changing, the impact of AAV and the potential loss of the episomes would be way more impactful. We don't understand comorbidities yet in terms of using AAV, whether it's safe to use in patients with, say, HIV, or indeed more recently, HCV now might become an issue. A significant number of patients have also had a history of an inhibitor, and we don't know whether gene therapy is applicable for this group. We have undoubtedly made huge strides in gene therapy in recent times, and we have always focused on safety first, as safety must be paramount in this. But as many of you are aware, some of the safety issues have come back to the fore again very recently, with Unicure's haemophilia B program being placed on hold because of the identification of one of the patients having hepatocellular carcinoma. This is uncertain as to why this patient got HCV. They have had it resected, but it is one of those issues that we've always thought about. What is the oncological risk with gene therapy? HCC can indeed occur in relation to AAV gene therapy. There are mouse models where high doses of AAV are associated with HCC occurring in mice as they age, but this has been associated with the use of non-tissue specific promoters, and enhancer elements can improve this, as can giving a lower dose of AAV. But perhaps most importantly, age administration is critical. Adult mice do not seem to carry the same risk as neonatal mice, and this may well be because AAV has a propensity to integrate at the site of double-stranded breaks, which would occur in high turnover rates or where we get DNA damage or DNA stress. We are looking at this as a field, and AAV long-term issues in terms of expression has become very important and is being considerably researched. But there are a number of AAV studies out there to date, 3,000 or more patients, and the safety of it is largely thought to be reassuring. But we have to think about it. Finally, to say gene therapy today is version 1. It's a bit like an old phone, but we did see the development of the mobile phone through to the future, and gene therapy will inevitably develop and move forward and become more technologically advanced and can address some of these issues. So that leaves us with a number of aspirations for the future. That is a gene therapy that won't be affected by immunity, cell turnover, can be used in all ages, is not going to be limited by comorbidities, and can importantly be redosed and dosed to a desired level. We're striving inevitably for the best. At the moment, we've got good, but I don't think that we can say that we're not going to get better and we're not going to get ultimately the best. The next generation is maybe different viruses, maybe non-viral systems, but certainly there will be another generation of gene therapy. And AAV is today's gene therapy for haemophilia. It isn't necessarily tomorrow's. So finally, to say this is a really exciting field, but there is a lot more to come. Thank you.
Thank you so much, Dr. John, and for this excellent talk. And now it's the time to move to the next presentation, which is off-the-shelf allogeneic CAR T cell. It gives me great pleasure to introduce Dr. Robin Benjamin. Dr. Benjamin is a hematologist with an interest in multiple myeloma, stem cell transplantation, and cell therapy. He leads plasma cell disorder service as well as CAR T cell program at King's College Hospital in London. Dr. Benjamin, please. You are mute, Dr. Benjamin.
Yeah, thank you for that introduction. Thanks for the invitation to speak. About off-the-shelf allogeneic CAR T cells, something that I've been involved with for the last few years. Next slide, please. Yeah, next slide. Yeah, so I think all of us are familiar with the two main types of CAR T cells that are available on the market now, which either have a CD28 co-stimulated domain or a 4-1BB co-stimulated domain. Next slide. And the main manufacturing process of autologous CAR T cells relies on cells being collected from patients through a standard leukapheresis procedure. The cells are then undergo a period of activation and cell expansion, where the receptor is introduced and the CAR transduced cells finally expand over a 2-week period. And these cells are then available for infusion back into the patient. Next slide. If you look at where the field has moved in autologous CAR T cells, we've moved from the very first generation CAR T cells in the 1990s to the second generation CAR T cells in the 2000s. And it was only when the second generation receptors were introduced did we find that these cells were actually effective in patients. And the early studies in 2007 relied on CAR T cells being infused without lymphodepletion. But it was finally when lymphodepletion was introduced as a strategy before CAR T cell infusion did we see the results that we see today. And in 2017, we had the first approval for BALL, followed not long after by CAR T cell approvals for diffuse large B-cell lymphoma. And then not so long ago, we've had approval for mantle cell lymphoma and a further product, liso-cel, for diffuse large B-cell lymphoma. And I think we're all waiting eagerly this year for potentially CAR T cells to be approved for multiple myeloma. And there's a very good chance that that might happen. Next slide. But I think whilst undoubtedly the autologous CAR T cells have given us some very good results with about 50 to 60% remission rates in BALL, about 40% remission rates in diffuse large B-cell lymphoma, in multiple myeloma, we're not seeing long-term durable responses. Having said that, we are seeing very impressive early response rates. So I think there is still the prospect for improvement on these early products and these early trials. Next slide. So I think it's the case that with autologous CAR T cells, there are a number of challenges. One of the challenges is manufacturing failure, which can occur in lymphopenic patients. And the whole logistics of generating autologous CAR T cells is a significant undertaking. There is difficulty in treating patients with rapidly progressive disease, where unfortunately there just isn't enough time to manufacture the cells and get them back to the patient prior to the patient just deteriorating. And inevitably there is variation in the quality of the product from one patient to the next. And there are some disease groups, like for instance in CLL, where the T cells are fundamentally dysfunctional, and even when you introduce a CAR into them, the final product does not work so effectively. And all of this results in a very, very expensive product. We know that the list price for a CAR T cell product is something like $300,000 to $400,000. Now, I'm sure that will come down with time, but currently that is a significant limitation for many countries around the world. Next slide. So it's in order to try and address these challenges that allogeneic CAR T cells have been explored by the whole field. And when we talk about allogeneic CAR T cells, I'm not talking about CAR T cells derived from the donors following allotransplant. We're talking about off-the-shelf products now. So these are products which are pre-made. You have standardized, validated batches of cells that are only released when you know that they actually work. And because you can scale this up, you have reduced production costs. There is the potential for multiple infusions, something that is rarely possible in the autologous setting. And because these are cells that are pre-made from young, healthy donors, where you can pre-select a healthy T cell, it has the potential to be more efficacious than patient-derived autologous CARs. Next slide. But what are the obstacles to allogeneic CAR T cells? Well, the biggest obstacle is the fact that you've got a HLA mismatch product here with the potential to cause graft versus host disease mediated by the donor TCR. These are cells that can be rejected by the host immune system, and the rejection can occur through a variety of different means by both T cells, NK cells, and B cells. We know that even in the autologous setting, you get infections as a potential complication. In the off-the-shelf CAR T cell field, there is the prospect of even more severe infections, partly because of the more intensive lymphodepletion that is generally used for this product. Next slide. So what are the strategies that we can undertake to try and generate an allogeneic CAR that can be given to any patients? Well, in this schematic diagram is shown the barriers to this and the strategies to overcome these barriers. So in most cases, you'll see that the endogenous T cell receptor needs to be disrupted so that this CAR T cell that's introduced into the cell can actually proliferate without causing graft-versus-host disease. And this is generally done by a variety of different gene editing techniques to knock out the TCR alpha gene. There is also the prospect of knocking out the MHC class 1, and one way of doing that is to knock out beta-2 microglobulin. That's something that a number of different groups have tried to do. But what about the host immune system? You've got to find a way of preventing the host immune system from rejecting these cells. And one of the ways in which people have tried to do this is by using an intensive lymphodepletion, using an agent like alemtuzumab, an anti-CD52 monoclonal antibody. And this gives profound host immune lymphodepletion and prevents the CARs from being rejected. But in order to make the donor CAR T cells invisible to the alemtuzumab, because otherwise they would just be killed by the infused alemtuzumab that has a long half-life, the cells can have their CD52 knocked out. So now these cells can no longer be seen by the alemtuzumab and expand via the CAR. Next slide. So the very first off-the-shelf CAR T-cell product that went into patients was this one, UCAR19. And I've been fortunate to work with this through one of the trials. And the strategy employed with this specific product was to use TALENs to edit out the TCR alpha gene and the CD52 genes. Lentiviral vector was used to introduce the CAR, which had a 4 BB co-stimulated domain, and it also had a CD20 suicide gene built into it, which in theory allowed these cells to be eliminated by the use of rituximab. Next slide. The manufacturing process involved collection of cells through a standard apheresis procedure from a healthy donor. The cells were activated, lentivirally transduced to introduce the receptor. The 2 TALENs for 52 and for TRAC were electroporated into these cells. They went through an enrichment process then to select out for just the TCR alpha and beta negative cells, and then frozen down, ready to be infused into patients. And you'll see that these cells are 99% free of TCR alpha beta cells, although there is still about 1% of cells that still express a donor TCR, which have the capability of causing graft-versus-host disease. Next slide. So these are the 2 trials that have just been completed now, looking at UCAR19. First one was the CALM trial, and this was in adult BALL. It was designed as a phase 1 dose-finding study with 3 different dose cohorts. The pediatric study just had a single flat dose, but using the same product. Next slide. And the preliminary results from these 2 studies were recently published in the Lancet. And what you'll see from the baseline characteristics of the patients, at that time there were 14 patients treated on the adult study, 7 in the pediatric study. You'll see that the majority of the patients had had more than 4 prior lines of treatment. More than a third of patients had had either inotuzumab or blinatumomab, and the majority had had a prior allogeneic stem cell transplant. So a high-risk group of patients. If you look at the disease burden going into the trials, they ranged from MRD levels of disease to frank relapse. Next slide. So what about the toxicity profile that was seen in the study? Now, 91% of the patients developed cytokine release syndrome, but only 15% had grade 3 or more CRS. So I think this is in keeping with what you might expect to see in CD19 CARs for BALL, for instance. Neurotoxicity was seen in about a third of patients, but again, it was mainly grade 1. And very fortunately, we only saw 2 cases of graft-versus-host disease, both of which were grade 1. We did see a lot of infections. 62% had some form of infections, mainly grades 1 and 2, although we did see more viral infections than you might expect with the autologous CARs, and that is predominantly because of the use of alemtuzumab in the lymphodepleting regimen. We did see some cytopenias, and this is again a common finding amongst patients that receive CAR T-cell products. But patients that had prolonged cytopenia in our study was about a third of patients. Next slide. So this was the efficacy reported in those 21 patients treated. And do bear in mind that the way the study was designed was that the patients received a CAR infusion following FCA lymphodepletion. Once the patients achieved a remission, then the majority of them went on to have an allogeneic stem cell transplant. And the main rationale for this was because the expectation was that persistence of off-the-shelf CARs may be limited, and therefore one ought to take the opportunity to consolidate these patients with an allo stem cell transplant. And you'll see that 67% of the cohort as a whole achieved a complete remission following UCAR19. This was at day 28 post-treatment. That's 14 out of 21 patients treated. 4 out of those 21 patients did not receive alemtuzumab. That was just because of investigators' choice and worry about viral infections. And you'll see that none of those patients who did not receive alemtuzumab responded. So if you were simply to look at the cohort that had fludarabine, cyclophosphamide, and alemtuzumab, 82% of these patients had a complete response, suggesting that you do need alemtuzumab for expansion of this particular CAR T-cell product. You'll see in the triangles that there were a number of deaths that occurred following the transplant. So some would have been standard transplant-related complications. Others were deaths from progressive disease. Next slide. And I guess whilst the initial response rates were very encouraging, if you look at the durability of the response, this was rather disappointing, with a PFS of only about 27% at 6 months and overall survival of 55% at that stage. Do bear in mind, though, that for the adult study, half the patients would have had very low doses because this was a dose-finding study. And the first dose in the adult study was only about 1 × 10⁵ cells. So considering the cell doses were rather limited, an early response of 82% in alemtuzumab-treated patients, I think is an impressive first start for the field. I think the challenge is now to try and improve the durability of these responses. In the next slide, you'll see perhaps why the responses are not that durable. Next slide. So this slide shows the expansion kinetics of the CARs, and you'll see that although in the majority of patients who received alemtuzumab, you get an initial expansion of CARs as expected, peaking at about day 14, you then get a gradual decline by day 28, and beyond day 42, there were only 3 patients that had persistent CARs. And this fundamentally might be the reason why you're getting relapses occurring. Now, in not all patients could you assess the long-term kinetics because they all went on to have allotransplants, so you would ablate the CARs in any case. So I think it is still unclear as to what sort of long-term persistence you would see if, for instance, these patients did not have a subsequent allotransplant. But what was clear in the slide below, you'll see that, expansion did matter. If you didn't expand, you didn't respond, shown down here. Next slide. So the field is now starting to look at other ways of generating allogeneic CARs. And a number of groups have looked at genome editing ways of generating this. And the way one way of doing this is to actually generate a CAR, a CD3 anti-CD3 CAR that actually functions to retain the CD3 complex within the endoplasmic reticulum and stops it from being expressed on the cell surface. So in other words, you're getting rid of the TCR, but not by using a gene editing technique. And this is another CAR that will go into the clinic hopefully very shortly. Next slide. And the Memorial Sloan Kettering group have looked at ways of introducing, of disrupting the TRAC locus by introducing the CAR into the TRAC promoter area. So it achieves two things. It disrupts the TRAC locus, but it also ensures that the CAR is now under the constitutive expression control of the TCR promoters. And what they've shown, certainly in their preclinical work, is that you get very stable expression of the CAR in this context without any expression of the endogenous T-cell receptor. Next slide. So these are some of the ongoing allogeneic off-the-shelf CAR T-cell trials. Allo501 was a study reported in the US at ASH last year in DLBCL, again showing some encouraging early responses, but perhaps not durable responses. UCAR123 is a off-the-shelf CAR that's being explored in AML. Similarly, CAR against CS1 is also being looked at in myeloma. And the Allogene group have also reported their early findings of an anti-BCMA AlloCAR in multiple myeloma. Again, early encouraging responses, but the proof will come in whether or not you can make these responses durable. Next slide. So these are some of the alternative off-the-shelf cellular therapy products that are being used to introduce CARs into patients. NK cells have had a lot of publicity from the work done by Katie Rizvani at the MD Anderson. Gamma delta cells can also be used in isolation, but also by introducing a CAR into them. The invariant NKT cells are also being used, and NK cell line CARs and iPS-derived CARs. So I think you're going to see in the next couple of years a whole series of different types of off-the-shelf CARs that are being explored. Next slide. So just to summarize, allogeneic CAR, off-the-shelf CARs can be an option now, where autologous CAR T cells are challenging or unable to be used. We demonstrate from the CARM and PAL trials that it is feasible and it is safe to use allogeneic CARs, but there are still some issues with toxicities and lack of persistence that we do need to overcome. And I think the field will move forwards with the next generation allo CAR T cells. I just want to end with a final slide, which just throws a number of questions. So these are some of the questions for the allogeneic CAR T cell field: whether or not they can persist long enough for durable disease control, who makes a good allogeneic CAR donor, and ultimately, will off-the-shelf allo CARs be cheaper and more accessible? And after all, that's the main purpose for this. Thank you.
Thank you so much, Dr. Benjamin, for this elegant talk. And now we will come to the questions. As you have seen, CARs and gene therapy is growing rapidly, even probably in the coming few years, more than mobile phones. So I have a couple of questions. We'll start with Dr. Arkin. The first question: does BCL11 modification is the only promising gene editing for hemoglobinopathies, or there are many promising targets other than BCL11?
Yes, can you hear me? Can you hear me?
Yes, yes, go ahead, please.
Okay, good. I think I tried to sort of allude to that during the talk, that there are other targets right now. BCL11A is sort of the furthest along in terms of the gene editing, either the enhancer or the binding site, the promoter, which will come, I think, into clinical trials. Certainly, there's still a role for lentiviral globin addition, although there's some concern with the latest hold. There may be additional targets that could be exploited, perhaps LRF, although it may have support cellular consequences. And the other is still the question about homologous repair, and those correction of the actual specific mutation. The frequency for that is still somewhat challenging. I think for sickle, obviously one has to fix only one mutation. In talking about thalassemia, you'd have many different mutations. You have to do a correction for each one. I think the attractive feature of reactivating hemoglobin F is that it basically is an approach to the therapy of all the hemoglobinopathies and all the different mutations in thalassemia. So it is sort of a one-stop approach to the problem. But I think it's a fast-moving field, and we'll see whether there are additional targets.
Thank you. Same thing. Do you think this technology will be available soon as a standard of care treatment for such patients?
Well, the technology is still in the early trial phase. I think hopefully there'll be enough experience to approve some of these therapies, but because they're really resource intensive, they involve mobilizing stem progenitor cells, modifying them, and reintroducing them to preconditioned patients, which is essentially bone marrow transplant. It will still be a procedure that's really for high resource environments and hospitals. So it won't solve the burden of disease by any means, and it will take a while to really make it to many different areas.
Thank you so much. I have the next question for Dr. Passy. What was the failure rate in gene therapy trials in both hemophilias A and B? And was there any specific reason for those failures?
Okay, so it depends what you define as failure rate. I mean, you could define failure as failure to meet the sort of original trial target, or you could define it as failure to produce any clotting factor at all, or thirdly, failure in terms of factor is expressed, and then due to an immune response, typically CTL against the liver, you lose all your clotting factor expression. So I'm going to just sort of try and touch on those as we go through. The first thing to say is there is huge variability in the response in gene therapy. So we can see, tenfold variation, if not more, between expression levels. The actual rate of patients not responding at all is a bit difficult to judge from the phase 1 and 2s, but it might come out more from the phase 3. And if you look at the BioMar in preliminary data at the JP Morgan, you can see that there were a number there. There weren't any in the Unicure study, but there were patients that expressed in both these at quite low levels. So as I say, it depends how you define it. What your question though is exceptionally important, because outside the context of a clinical trial, when these therapies become potentially commercialized, the rate of failure, the degree of reliability that you're going to deliver a clotting factor level that means something, that's going to deliver some impact for you, is going to be hugely important to patients. Because if you've got a arguably 10% rate of it not going to work at all, then are you prepared to take that risk? Because gene therapies with AAV are a one-off. Once you've had one, you're not going to get it again. And once you've had one person's gene therapy, you're not going to be eligible to anybody else's, because there's such a high level of cross-reactivity between the antibody response once it's been expressed. So it's a phenomenally important question. That's been a very long-winded answer to say that we don't actually have the figures yet. But is it a critical question? Without a doubt.
I think we've lost Dr. Ali. Is Dr. Ali with us? I might come in with a question for Ruben. Ruben, thank you very much for your talk on the transplant. So if I can ask you, so also obviously encouraging results for the allogeneic trials. Moving forward, I mean, what other technologies do you think are going to come? What are the most likely things that are going to happen in the allogeneic field to bring that survival curve up? And once that does happen, is that the death of a lot of the autologous programs?
Are you hearing me?
Yeah, thanks, Said. I think the death of autologous CARs, I don't think is going to happen for a long time yet. I think there's a lot more work that needs to be done in the off-the-shelf CAR T-cell field. But nevertheless, I think we all recognize that there are huge numbers of patients that currently are not being served by autologous CAR for a variety of different reasons. Where I see the developments happening, I think there are going to be refinements in the way in which we deliver the allogeneic CARs. So, for instance, we had no idea at the beginning of the studies what dose of alemtuzumab to give. Too high a dose, you end up with more infections. Too low a dose, you basically end up with insufficient lymphodepletion and early rejection. So getting that sweet spot, and that sweet spot was different for different patients because in some patients you had very high CD52 disease burden, others you had low disease burden. So it was very tricky to work out the optimal lymphodepleting strategy. But I think there will be further advances made in the current trials of lymphodepletion strategies. The other developments are to do with the actual engineering of the cells themselves. This particular cell only has a TRAC knockout and CD52 knockout. I think if you knock out beta-2M and you introduce elements like HLA-G or HLI that have an inhibitory effect on NK cells, you minimize the rejection of these cells, and you may not need to give as high lymphodepletion as we are now. So I think the next generation off-the-shelf CARs will probably persist for longer, and I think that's where we might start to then see improvements in the survival. It's clearly not possible to be doing allotransplants in everyone. I mean, in the ALL context, maybe yes, but I think in other diseases like lymphoma and myeloma, we're not going to want to have off-the-shelf CARs just as a bridging strategy. So I think that's where I see there being advances being made, further engineering of the cells to make them persist for longer.
Thank you very much. I'll hand over again to Dr. Ali Al-Ahmari. In case we haven't. Dr. Ali. Okay, I don't think if there aren't okay, there might be a few more questions. Yes, in the chat over here, I'm going to take over. For blood scratias like dysfibrinogenemia and intrinsic factor deficiency, no, sorry. I think this might have been to another speaker. Yeah. Okay. If I can ask Dr. Stewart, I'm sorry, I'm just trying to find questions here. What is your opinion, Dr. Stewart Orkin, on the base editor technique? Is it as great as CRISPR-9 results in thalassemia patients?
Yeah. So base editing is certainly another new and exciting technology. It has the advantage of not involving a DNA cleavage, so it might be safer perhaps. And certainly, as I mentioned, for example, the binding site for B11A in the gamma promoter is a site where base editing does disrupt that site. It will be brought to trial. There is at least one company that's bringing it to trial. I'm not sure whether the efficiency yet is as good as CRISPR editing. But I think in a way this is an embarrassment of riches. We have many different approaches, many different technologies coming along, and I think the proof will have to be in really the clinical studies to see what is the relative efficiency, benefit, risk of each one of these. But I think it's certainly on the horizon.
Thank you. Another question to Dr. Passy. What was the failure rate for both the gene therapies for hemophilia 8 and 9, and what was the reason for failure?
Okay, I think I answered that question earlier. It's the same one,
sorry, my mistake.
actually. No, don't worry.
I'm having to fill in. So, then I'll have to bring the question to Dr. Stuart Orkin again, which was about the role of hypomethylation. Yeah, from a genetics point of view, do you think methylation has the same influence in repressing gene expression? I don't think that one's asked.
Yes, I think this question is based on the sort of conventional wisdom or feeling that DNA methylation is inhibitory for expression of at least the gamma genes. It's really that really comes from a correlation. It is not showing a causative chip. And our own feeling is that the methylation is a late step in silencing and really is not determining, and therefore really is not going to be a barrier in the therapies that are currently being discussed. So I think it's an interesting question, but I think it's probably a minor contributor to the process.
Thank you very much. Prof. Passy, if I can come to you with a question. Obviously, the recent reports of the malignancies have been a concern and an unfortunate sort of break to the rapid progress that we were seeing. I know this is a difficult question, but you know, the medical field and researchers are resilient. How big a setback do we think this is going to be? And what do you envisage in terms of the time it'll take for the field to get back on its feet? And I suppose this is a question to both Dr. Orkin and Dr. Passy. How do we see the field moving forward given these setbacks?
Okay, so in the haemophilia world, it's been quite an issue. It's because there's always been a concern, all gene therapies, about insertional mutagenesis and cancer. There's obviously the stuff about the neonatal mice, which has reared its head again, and insertional breaks, insertion at double-stranded breaks. So the HCC has rather ticked the anxiety boxes in many haemophilia treaters and people in the field. But it's not as straightforward as just saying, oh, this is probably linked. We don't know. The patient who developed the HCC with the haemophilia B program developed it 14 months after the treatment, which in HCC terms is probably really quite short. They were previously treated for HCV and cleared it with second-generation antiviral therapies. We don't know, more importantly, what the original genotype was, because there is quite a significant rate of HCC in patients who have been HCV sustained virological responders to treatment. And it's said that with some genotypes, like genotype 3, the risk might be as high as 10%. So the further studies on the resected material from that patient are going to be absolutely critical, and it's going to boil to, there are lots of different scenarios you could propose, but essentially, is there HCV in the clonal malignancy and has it inserted, and can you propose from where it is, if it's there, that it's likely to be relevant? So that's the bit of information I think everybody's hanging out for. There's the dog data about insertions, relatively limited but longer term, but it certainly made everybody take a big step back, and then start to reevaluate, should actually we be just taking patients without this as a comorbidity. So if it isn't HCV related per se through integration, is it HCV related because of liver instability? Should we just be treating patients who've never been exposed to HCV? So it is having a big impact right across the field, haemophilia A and B, whoever's technology, but we don't have any definitive answers at the moment. How long it'll take to sort this out in terms of reassuring the treatment population, the treater group, that it's safe, I don't know. I think we'll probably have some scientific answers before that. But the other thing is that we have lots of patients that have been treated with AAV, but most of those that have had liver-directed treatment have been treated since 2015 onwards. So we've got a relatively short period of follow-up. So probably there I've given you more questions than answers to your actual one very simple question: when will we feel better about it? I don't know.
Dr. Hawken, your view?
Yeah,
When will we bounce back?
Yeah, I think my answer would be fairly similar. It's sort of like that Gartner search cycle that Dr. Posse showed, that hype and disappointment, and then you come back to a plateau. I think in the case of the recent hold on the Bluebird trial with the lentiviral globin gene addition and sickle cell, it's investigations are going on now to try to figure out to what extent that was related to therapy, and if related to therapy, what aspect of therapy. What's interesting about it is that the same vector has been used in the beta thalassemia trials in Europe with really more experience and longer time, and there's been no such adverse effects like that. So one would have to propose it's either something related to sickle patients, related to a different dose of virus that may have been given if it was increased, or related to the genotype of the patients that may have been predisposed to myeloproliferative disorders, or just bad luck. I don't think we know the answer, and the lentiviruses, at least for the hematopoietic field, have been considered relatively safe, the latest generation, but obviously this is going to raise some concern. What it may do is stimulate or encourage more activity in the editing field, either CRISPR-Cas9 or base editing, if it has to do with the lentis. But of course, if it has to do with preconditioning of patients or some other aspect, then it may not, it may not free the editing field of that concern. So I think we don't know. Hopefully the hold won't be too long. Hopefully this field will be able to progress. I think it's most unfortunate that it occurred in the sickle trials, because at least in the United States, these patients have been most reluctant to participate in clinical trials given sort of historical issues. And it's just another disappointment for that disease. But I think we'll find out from additional studies. So I'm still optimistic. I think the field still will move along, but I think we need to get through this to see whether it's related to the therapy and what aspect of therapy.
Thank you so much. I think we come to the end of our session. We have enjoyed the 3 elegant talks by 3 world leader experts in their field. And I would like to thank the speakers. I would like to thank participants for joining us in these sessions. I can see now more than 4,600 attendees. So thank you so much all for joining us. And I would like to close the session and have a fruitful rest of program. Thank you so much.
Thank you.
Go. Dr. Go, doctor, go. Good evening, everyone. Thank you for joining us tonight in the second session. We have almost 4,000 attendees. We're excited to talk about NK and different CAR T cells. We have with us today Dr. Rafat Qasar from MD Anderson. Dr. Rafat.
Hello.
Thank you for joining us tonight. We're eager to listen to your talk. It's a very exciting time to add on to the arsenal of the different CARs. Dr. Rafat Qasar is an assistant professor in the Department of Stem Cell Transplantation and Cellular Therapy at the University of Texas MD Anderson Cancer Center. He has developed expertise in multiple immune cell subtypes, including NK cells, T cells, and B cells, and is leading multiple exciting translational projects simultaneously. Dr. Qasar, thank you for joining us tonight. We can't wait to hear your talk. The mic is all yours. Go ahead.
Okay, thank you so much, and thank you for inviting me on the forums like this beautiful the Congress. So again, I'm good morning, everyone, and thank you for joining our to discuss. As he mentioned, I'm a assistant professor in the Department of Stem Cell Transplantation in MD Anderson, and also like to thank the organizer for inviting me to discuss chimeric antigen receptor in the application of immunotherapy. So here is my disclosure. We have recently the financial conflict with the Takeda Pharmaceutical Company for CAR NK cell technology. So just to basically mention for with the chimeric antigen receptor. Chimeric antigen receptor is the recombinant molecule consisting of the three parts. The first part, as you saw here, is the single chain variable domain, which is the antigen specific and from monoclonal antibody. And the second, they have the transmembrane domain, which can be, which I'm going to mention about the importance of this domain. And the last is this the signal transduction domain of T cell receptor, which is usually they use CD3 zeta. So when CAR T cell recognize specific antigen, the cell is activated via the intracellular signal transduction domain and the exertant target cell toxicity. So just basically, I want to select a little mention about how T cells are working, and when you put the chimeric antigen receptor on the surface of T cells, how they are working. Normally, T cells they interact with the antigen specific antigen presenting cells, such as dendritic cells, to be activated via the T cell receptor. But to augment them, this activity, they need to have some other costimulatory domain. When I talk about the CAR generation, why it's so important, we're gonna see over there. And after this engagement, T cell they start to activate and they kill the target. And this all is MSC dependent. Is important to know this. But when you come to the CAR T cells can recognize with the SCFP part of these CAR T cells via antigen recognition domain and is not MSC dependent. When CAR T cell recognize a specific antigen, the cells activated via the intracellular signal domain and exert target cell toxicity. So here you can see the different generation of the CAR T cells from the first generation. Then now just for CAR NK cells that I'm gonna mention the fourth generation armored CAR T cells. So as you know, just they refine them gradually, and the first was just the first generation just with the CD3 zeta without costimulatory domain and with the ACFE. So this first generation showed limited expansion and anti-tumor efficacy because the CAR T cell expansion in vivo was just dependent on interleukin production. But when you the thing, as I mentioned in previous slide, for T cell in vivo T cell activation, is caused by interaction between antigen presenting cells via T cell receptor, and they need to augment like the T toxicity. They need like the several like the costimulatory receptors such as CD28, 4-1BB, which is you can see like for second generation like the CAR that develop like the right after that, which like the to increase the persistent anti-tumor activity, they put like another costimulatory molecule, either like 4-1BB and CD28. And then there is like in two different like the drug in 2017 when they accepted one of them with the 28 for like the higher antitoxic activity, and another like the for higher in vivo positive for 4-1BB. To further augment them select these anti-tumor activity in persistent, we have them select the third generation, and then as I'm gonna mention them select for current cases, we have them select the fourth generation that armored with the cytokines such as IL-12, IL-15 that they can improve the proliferation and the in vivo persistence of these CAR cells. So you can see here briefly how I'm select the patient CAR T cell generated, and then I'm select going to select the patient is quite select the complex, and the time I'm select the consumer I'm select the process. So then patient I'm select are collected via leukapheresis, and then subsequently transport in a manufacturing facility for ex vivo genetic modification. First, this leukapheresis material undergoes enrichment for target T cells with the positive selection with CD4 and CD8. Then T cell undergo activation and the viral transduction, as you see here, with the chimeric antigen receptor target against the specific tumor antigen such as CD19, BCMA. And then these transduced cells further culture expanded, formulated, and cryopreserved. And then final formulate this CAR product is then shipped back after I'm selected region chemotherapy, and then administered to patient via infusion in single dose. So as I say, just like in the previous email, the reason selected in the United States now, we have them selected in FDA approved them selected three different products. One of them is Yescarta and the Chimera. Yescarta and the Chimera is they approved by FDA in 2017. Yescarta for diffuse B-cell lymphoma, and Chimera is for acute lymphoblastic leukemia. But later on in 2018. They accepted approved for the diffuse large B-cell lymphoma, and recently also like for mantle cell lymphoma, again from the same company, Tecartus is approved for mantle cell lymphoma. Actually, I'm select one of my slide is missing. So, but in that I'm select the slide. We just selected with the Chimera and the Yescarta. There was like the clinical select trials. Dr. Benjamin select to mention about this. Select the clinical results with the Yescarta and the Chimera with the diffuse large B-cell lymphoma. There was like less response, but with the both of them with acute lymphoblastic leukemia. Both they have select around overall select response around 80-85 with the like 50-60% of the complete response. And the Tecartus recently it was conducted by MD Anderson by Dr. Wang also. It was a mantle cell lymphoma. They got 85 overall response, and 59 is 59% of complete response. But like for all of them, again, there was like really missed the side effects with the CRS and the neurotoxicity. So this figure summarizes the limitation of the achieving durable selective remission with the chimeric antigen receptor CAR T-cell therapy. Quickly, I'm going to mention about this. First of all, CAR T-cell failures have several causes for some patients. And this CAR cell product cannot be successfully manufactured, or to generate the CAR T cell do not expand sufficiently. This either can be manufactured in vitro or after administration in vivo. And in other patients, also the problem of limited persistence in vivo is potential mechanism of underlying selected disease relapse. And the second that is really like the common also this is the antigen modulation. So depicted by the loss of downregulation. See some like this in the clinical trial. We have seen them select with CD19, CD22. I'm select on malignant B cells. These like when they downregulate these, they enable antigen escape as a mechanism of resistance to CAR T cell therapy, which can also be a problem with the non-B cell malignancies as well. And the third, like as I mentioned in previous slide, also the characteristic toxicity of CAR T cell therapy, primarily like the severe, like the cytokine release syndrome, almost like around 50-60% of patients they experience the neurotoxicity or severe like the cytokine release syndrome. And these like the side effects, they can be fatal, but this does like abolishing the potential of therapeutic benefit in a small proportion of patients. So, and then furthermore, data on the effect of the therapeutic intervention of the CRS and the durability of CAR remission is remain unknown. And finally, unmet needs include some disease contexts that are a focus for ongoing research efforts to optimize the clinical utility of CAR T cell therapies. For example, although CD19 CAR T cell can provide substantial benefit for adult lymphoma, the complete remission rates are lower than those achieved in patients with the leukemia. And additionally, the outcomes of this might be like because of the they have much more like the complex microenvironment. And additionally, the outcomes of CAR T cell therapy in pediatric patients with the lymphoma, in patients with the central nervous CNS disease, remain in array of ongoing investigation. And notably, such therapies currently have limited efficacy in patients with solid tumors, and approaches to optimize response are being explored. So as I mentioned, like the autolog, like now what's available. Dr. Benjamin also mentioned about like the effort that they're trying to like move the allogeneic CAR product. CAR T cell production, this complex manufacturing process is compounded by time-sensitive logistical matrix with many stakeholders and potential of failure. And these and other factors are challenged to be overcome with autologous like the CAR T cell therapy. As you see here, like we need to move with some like for CAR T cell or other like the immune subset, we need to move to allogenic. For allogenic can be like from PBMC, umbilical cord blood, embryonic stem cell, or immunopluripotent stem cells. We have like off-the-shelf product. This is going to eliminate the manufacturing time and allows true point of care administration, and then can scale much larger numbers of like the product. So as again, like as I mentioned, like in the previous like the presentation, we have like the possible like possible target that we can like move with the CAR T cells for allogenic product, but what we can like the target first problem with the like HLA class 1, if is recognized by like body the T cells, they can be like reject. And the second, if you have endogen TCR, they can attack somatic cells and they can cause the GVHD. To overcome this, like the recently last couple of years, like the CRISPR-Cas9 gene editing technology actually is not just CRISPR-Cas9, but with the TALEN, with zinc finger, they become like really popular. With that, as you see here, you can remove like the endogen HLA class 1 and 2, and then with that, just like the patient T cell, they're not gonna recognize, and they're gonna have like long-term survival. And then when you remove the endogen TCR from the T cell that we're gonna infuse, then you're gonna avoid from the somatic cell attack that probably can cause them like the GVHD. So there is the clinical trial which Dr. Benjamin mentioned about that with this, like the overall response in the beginning was good, but when you look at them, like the overall response was not like really good, but the working on it, it's like still research on that is ongoing. So today actually is like since we have like all these challenges about them, like the CAR T cells, and the researchers start to look like other possible immune cells that we can use for CAR like the cargo, and then we can use as effector cells. So in our lab with Dr. Rezvani, she started to work with the NK cells like over 10 years. So today I'm gonna mostly I'm gonna talk about like the NK cells. Just a brief introduction for NK cells. for those who are not familiar with the NK cells are members of the innate immune system, which can be defined as CD56 positive and CD3 negative, and they differentiate in the bone marrow and possess no need for antigen priming. They are primarily found in the blood, and the key advantage that NK cells provide is that they have little to no risk of the GVHD. Actually, there is a lot of the studies is going on about that NK cell can be used for GVHD actually. And this another characteristic of NK cell is that their recognition takes place through the complex array receptors. So when you compare CAR NK cells with the CAR T cells, they have the number of the advantage of CAR NK cells, that we can produce allogenic product is the off-the-shelf with the possibility of procuring more than 100 doses, which I'm going to show you in the next slides, from only one cord blood unit, which impact the cost of production of treatment. When you think the price of the CAR T cells for each single dose, so it's really the big achievement with the NK cells. So combining these advantages with the low likelihood of GVHD and the other side effects such as CRS, which is common in CAR T cell therapy. And in addition, CAR NK receptor provide a functional advantage as NK cell can bind ligands expressed by tumor cells such as MICA, MICP, and LPP. But when you think about the CAR T cell, they're gonna kill them the target just with the CAR-mediated killing, but CAR NK cells, they can kill by their receptor, natural ligands, and the receptors, and by CAR as well. So CAR T cells, I show you the same slide actually. There is no really the big difference between the production of the CAR NK cells. Again, number of researchers, they're using them the different source of NK cells. They're using PBMC, NK92, umbilical cord blood, embryonic stem cells, and iPSC. So from these, they sorted NK cells with negative positive selection. Then these NK cells, I'm going to mention about the aurums, the protocol about expansion. They activated or expanded this as then they transduced with the chimeric antigen receptor with the viral vector, which is we're using retrovirus. And then they're giving them more activation and more expansion, and then after that they infuse the patient. Again, I'm the single dose. So in our lab, in MD Anderson, we have huge cord blood bank the facility. For that reason, just we start to move with the cord blood. The advantage of this readily available from global cord blood bank, and this lymphocyte composition include 15-30% of the NK cells. And the more important, these NK cells, they have high proliferative potential transcriptomic profile. They have, of course, some disadvantage. They're numerically few and therefore requires ex vivo expansion. And there is variability between products. Some of NK cells from some cord blood, they are doing better than the others. So, as I mentioned before, NK cells are a good alternative for immunotherapy with many advantages in regards to side effect and cost effective and availability as one of the shelf product derived from cord blood. To take these the step further, our team developed an armored NK cells, which is the 4th generation CAR with enhanced anti-tumor activity. So we decided to transduce our NK cells with the chimeric antigen receptor. In this schematic, you can see the design of our construct, which was generously provided by Pietro Dotti from Baylor College of Medicine. So they compromise suicide gene just in case of toxicity, along with costimulatory domain with CD28 and CD3 zeta. And to improve proliferation and anti-tumor activity, we incorporate with IL-15. So this is my colleague Emily Liu. She transfused them in cases with the chimeric antigen receptor, then tested their in vivo persistence and anti-tumor activity after infusion in NSG mice. And then the mice, they engrafted with the Raji, which is really a highly aggressive B-cell tumor model. As you can see in the first row, just in 2 weeks, non-engineering NK cells, and the tumor alone, they succumb with the tumor. When you have like the CD19 CAR without IL-15, they do get control some, but like after a week or 2 weeks, they again like they succumb with the regime, and then finally they died because of like the tumor toxicity. When you come with the CAR-19, they incorporate with the IL-15, they control like tumor with much significantly better when you compare with the other group. And even I didn't show here, but it's like even day 70. When you look at them, select the peripheral circulation, you can see them select NK cell population that we infuse, which is really important. Usually, select is the one of the limitation of NK cells that they don't select the process as good as T cells in vivo, which means like with the IL-15 that it seems just that we overcome from this limitation. So using this method, we went to FDA and developed a GMP production protocol for expansion and transduction of CAR-NK cell from cord blood. We get our frozen cord blood, thaw them, cycle them, deplete PET and monocytes, and then the cells are expanded with the K562 based feeder cells, which we generate in our lab, which is they express IL-21. And besides, with some receptor, they can improve the proliferation and the anti-tumor activity of NK cells, 4-1BB and CD48. And then in the culture, we support with the IL-2. On day 6, we transduce the cells with retroviral supernatant, and then we do one more round of ex vivo expansion. So at the end of 2 weeks, we have transduced NK cells ready for the patient infusion. Before I'm select the infusion, of course, we're checking them select the phenotype of NK cell to make sure there is no any contamination, and we have the poor population CD56 positive, CD3 negative, and CD16 positive. So this table summarize the data on the expansion and the transduction efficiency of 5 different cord blood. I think just like the deal was gonna come. I'm select after I'm select the slides, but it just like the close. I'm selected the first 2 cord bloods. But we got them selected from the 5 different cord bloods. From each cord, we get around 20 to 50 million NK cells. And at the end of 2 weeks expansion, we can expand NK cells more than 2,000-fold with the excellent transduction efficiency, which is like the average 66%. And the absolute number, like around 10 billion current NK cells, we can achieve after 2 weeks. So this means that from 1 cord blood unit, we can potentially generate roughly around 100 doses of current NK cells at 1 million per kilogram. So with that, just like these, I'm selected by Dr. Katie Rezvani, MD PhD from MD Anderson Cancer Center, and we started a trial with the current NK cell therapy in patients with relapsed and refractory B-cell lymphoid malignancies. This slide summarize the schema. We picked the cord blood units with the match 4 out of 6 HLA molecules. In the first, because there was not necessary for NK cells, but FDA is asking in the beginning, so that's why we start with that. But the last 2 patients I'm gonna mention, we use them like the without looking them like the HLA match, we infuse the cells. And the patient comes, and then again we told the course select the NK cell, expand for 2 weeks, and then patient received lymphodepleting like they are doing with the CAR T cell with the cyclophosphamide and fludarabine. And then because of this was like the first clinical trial, we start with the very low dose, like with 100,000 per kilogram. Then we move to up to like 10 million per kilogram. So, so this
2 minutes, Dr. Bassar.
Okay. So with this is like our clinical summarize. Totally, we have like the 11 patients, and this is like 5 of them is CLL, 6 of them like the diffuse large B-cell lymphoma. The overall we got them like the 83 response, and the 7 of them like we have them like the complete response. And when you look at them like the last 2 patients also it's HLA unmatched, and we didn't see any toxicity. Is the most important. With any patient, we didn't see any neurotoxicity and the CRS. So this is the overall survival and the progression of selective-free survival. As you see here, just like the overall survival is around like the 83%, with the progression of selective-free survival is like around 79%. So this is the one patient that with the Richter syndrome, they got them to complete remission. This is like the 3 weeks ago before like CAR NK cell infusion. After we infuse CAR NK cells, after 30 days after PET scan, as you see here, they clear all the tumor in the body. So, and then when you look at them, select the mass cytometry from the same patient, as you see here, this is the B cell select the tumor burden. After 6 days, they remove all select the tumor burden, and they're really good select the NK cell engraftment. And this is another patient again. Select with the high select the tumor burden. After this is the pre-admission, and after you infuse the CAR NK cells, it says again select all select the tumor gone. There was like only just little bit select in the armpit. And when you biopsy these and then look at them select the composition of cells, they're all coming from the donor NK cells actually, which means just that they can traffic also tumor site. So, and then like one concern that we've been seeing like with the CAR T cells, we look at the severe the cytokine release syndrome. There is no any upregulation or cytokine release syndrome related cytokine. So just like the two slides is like more as you know, just like the since we have like the good results with these, just we're trying to improve that. As you know, just like there is a really good checkpoint for T cell, but there's no really well known just like the checkpoint for NK cells. They recently by Nick Huntington they defined them like the CISH, which is like the breakpoint for JAK-STAT pathway. And we decided and the knockout select this gene with the CRISPR-Cas9 to improve select the NK cell activity. And as you say here, just like after you knockout, you can see just like the how select the improved CAR NK cell functionality with no evidence of tumor with any organs that we check in pathology. So, as a conclusion, the CAR T cell revolutionized the treatment of the B cell malignancies, and the NK CAR is really good, a good alternative for CAR therapy, especially after is the first human clinical trial with the CD19 IL-15. So, with that, as I say, just like the CAR T cell now in the guide, but in the future, NK cells and iNKT cells, and the recent CAR macrophage on the way. I think just soon they're going to be clinical trial about this. With this, I want to thank, and this is my lab, my mentor, Dr. Rezvani, and my colleagues, May Dahar and the other, and then all stem cell transplantation. Thank you.
Dr. Basar, this is a very exciting talk indeed. NK CARs are going to solve lots of issues, especially for the overseas hospitals and institutes like ourselves here in Saudi Arabia. There would be an off-shelf option, good option with less toxicity. That's what I call the future.
Yes.
Congratulations on this great work. I'm coming back. Please stay online with us. We have a bunch of questions for you,
Sure.
but we have to move on to the second lecture for today. And after we conclude the lecture, we're definitely going back to the CAR NKs. There's lots of questions to be asked, and we're looking forward for some experts' answers there. Let's move on to the second lecture today. Let me introduce Dr. Saud Al-Haidi, one of the consultant hematologists in stem cell transplantation and cellular therapy department in King Faisal Specialist Hospital and Research Center. He'll be introducing his guest today. This is a satellite talk sponsored by Janssen. So Saud, are you online? Okay.
Yes. Assalamu alaikum. Can you hear me now?
Yes, I can.
Okay. So it's my honor to introduce Dr. Maria Matios. She is an associated professor of medicine at University of Salamanca, Spain, and also she's a director of myeloma program and a coordinator, a clinical trial unit in Salamanca University in Spain. As you know, Dr. Matias is member of an international myeloma working group, International Myeloma Society, and also EHA. In addition, she is an editor of many myeloma, editor in many journals, including Annals of Hematology, New England Journals of Medicine, and Lancet of Hematology. Dr. Matias has more than 140 papers in peer review, international journal, and it's my pleasure to introduce her. Our talk today gonna be current treatment options for transplant eligible in a newly diagnosed multiple myeloma. Without further delay, Dr. Matias.
Okay, so thank you very much. And honestly, I can expand my screen. Yeah, now, and I am going to try to move through the slides. That I think that it is not possible for me.
Sir, just double click on the screen and
So thanks for the kind introduction, and first of all, thanks for the invitation to this important meeting. And in fact, I had the opportunity to be in Saudi Arabia a couple of years ago, and my experience was great. So hope all of you stay safe, and thanks to Janssen for the organization of this satellite symposium. And I will talk about the management of newly diagnosed myeloma patients, and my talk will be concentrated on the transplant-eligible patients. Here you can see my conflict of interest, and I would like to start my presentation speaking or discussing a bit about the potential treatment goals for newly diagnosed patients with multiple myeloma. And the cure maybe is not a completely realistic possibility, although I think that with the new advances and the new options of therapy, we are going to be able maybe to cure some patients with multiple myeloma. But in principle, we have to try to prolong definitely the overall survival, to delay the progression-free survival, and of course, to try to maintain the quality of life of our patients. And today we know that the depth of the response is something relevant, and the maximal eradication of the tumor clone is going to be associated with a better outcome. And this is one of the main objectives we have to plan when we have a newly diagnosed myeloma patients in front of us. This is the role of the conventional complete response, the serological complete response that has been a typical endpoint. And when our patients with myeloma achieved serological complete response, the outcome was better, as you can see here in this slide. But in 2021, definitely we have to move forward the evaluation of the measurable residual disease, because this is, I would say, the new complete response. And here you can see how in a clinical trial conducted by the Spanish myeloma group, in this population, transplant-eligible, newly diagnosed myeloma patient receiving induction with RVD, followed by transplant consolidation and maintenance, the minimal residual disease evaluation, in this case by next generation flow before maintenance, established two different subgroups of patients. And you can see here how the group of patients achieving minimal residual disease negative presented a significantly better outcome in comparison with those in which the minimal residual disease was positive. And this has been confirmed in another large trial conducted in this case by the French group together with the Dana-Farber Cancer Institute, also in a large series of patients, including RVD followed or not by autologous stem cell transplantation, utilizing next-generation sequencing, sensitivity level 10⁻⁶, and patients achieving undetectable measurable residual disease had a significantly longer progression-free survival. And today, in 2021, we have to incorporate also the imaging assessments. into the evaluation of the response, because the concept of a complete metabolic response has been also incorporated. And this is a presentation from us 2020, in which newly diagnosed myeloma patients included in a clinical trial conducted in Italy put in context how patients achieving complete metabolic response presented a longer progression-free survival, as well as also longer overall survival. And when they decided to combine both complete metabolic response with minimal residual disease negativity, in this case by flow cytometry into the bone marrow, a specific subgroup of patients was identified with definitely an excellent outcome. So in the future, I think that this is going to be our main objectives when we have newly diagnosed myeloma patients transplant eligible in front of us. However, it's true that if you remember the progression-free survival and the overall survival curves I have just showed you, some patients, in spite of the minimal residual disease negative, they finally relapse. And there are two important points, two important concepts in which we are investigating in order to optimize the measurable residual disease evaluation. The point number one is the sensitivity threshold, because the International Myeloma Working Group guidelines recommend at least sensitivity of 10 to the minus 5, but we know in this meta-analysis published in Blood Cancer Journal in 2020, when patients achieved sensitivity level of 10 to the minus 6, less patients are going to be identified as minimal residual disease negative, but the hazard ratio for progression-free survival is lower, indicating that its value is much more strong. And the same concept is applicable to the sustained MRD negativity. It is so important as to achieve MRD negativity as to maintain it over time. And again, in this meta-analysis, you can see here how patients starting maintenance and maintaining the MRD negative 1 year after starting maintenance resulted in a hazard ratio for progression-free survival lower in comparison with the intent to treat patient population. So these two important points are going to help us to identify definitely the minimal residual disease negativity as an important, if not the most important prognostic factor predicting progression-free survival and overall survival. And the International Myeloma Working Group recognized in 2016 this new response criteria. My recommendation would be to utilize them if the technology is available, because definitely today MRD negativity is an important prognostic marker, and in the near future we will start to incorporate this MRD status in order to establish modifications in the therapy. If we focus on the management of the patients with a newly diagnosed myeloma patient, and we consider that our patient is transplant eligible, in 2021, definitely the chronological age should not be anymore the only factor driving our choice. And we have to incorporate the biological age together with the comorbidities, disabilities, even patients' preferences, in order to distinguish between transplant eligible and transplant ineligible. If our patient is definitely transplant eligible, maybe you agree with me that if we go to the European guidelines or the NCCN guidelines or whatever local, regional, or national guideline, the management usually includes induction, followed by autologous stem cell transplantation, consolidation, yes or not, and maintenance therapy. If we focus on the induction, it's true that today the standard of care are at least 3 drug-based combinations, VTD, BCD, VRD, or a new standard of care has recently emerged, and it has been recently approved by the authorities in Europe as well as in the US and in other countries, and it is based on VTD plus the monoclonal antibody anti-CD38 daratumumab. But when we go to the European guidelines recently published in EMASFAIR and in Annals of Oncology, you can see here how these combinations, the first option is VRD, DARA, VTD, VTD or BCD as second options if the first ones are not available, followed by transplant and maintenance with lenalidomide. We have to put in context these possibilities, and VTD has been a standard of care we have utilized commonly in Europe. And here you can see the experience coming from the Italian and the Spanish myeloma groups with a couple of clinical trials conducted many years ago. And in fact, what I would like to put in context here today is the longer follow-up for these two studies. Median follow-up of approximately 10 years, and you can see here how VTD resulted in a median progression-free survival of approximately 5 years, and important from the overall survival point of view, at 10 years, between 50 and 60% of the patients remain alive. So VTD has been an optimal standard of care we've been utilizing during many years as induction for this population. CyBorD would be another possibility. From my point of view, it's suboptimal because it has been compared with PAD or even with VTD, and it's inferior in terms of response rate as well as overall response rate. But if there is not any other possibility, of course, CyBorD is also a feasible and a possible induction regime. And VRD is another quite common standard of care. Definitely in US is the most common regime utilized as part of the induction before autologous stem cell transplantation. And I have to say that in Europe, in spite of our authorities did not approve RVD for induction before autologous stem cell transplantation, in many countries it has been also the standard of care. And one of the reasons is the French study or this Spanish study in which we included almost 500 newly diagnosed myeloma patients transplant eligible, and we utilized VRD as part of the induction and as part of the consolidation after autologous stem cell transplantation. And we did a retrospective comparison with VTD, and VRD was a bit better in terms of response rate before and after autologous stem cell transplantation. But the main advantage is the toxicity profile, because as you know, lenalidomide does not induce the peripheral neuropathy. But the new standard of care, as I previously told you, is VTD plus daratumumab evaluated in the Cassiopeia study. This phase 3 randomized study included over 1,000 patients in 3 European countries, and VTD 4 induction cycles transplant and VTD 2 cycles consolidation was the control arm. And in the experimental arm, daratumumab was added as part of the induction and as part of the consolidation. The primary endpoint of this study was stringent complete response after consolidation. And here you can see how response rate improved over time. And at the moment of the last follow-up, 54% of the patients receiving Dara plus VTD achieved a complete response, significantly higher in comparison with the 38% of complete response reported with VTD transplant and VTD as consolidation. I previously alluded to the role of minimal residual disease as an important endpoint, and in fact, in this study, approximately 60% of the patients achieved MRD negativity, utilizing either flow cytometry or next generation sequencing. And you can see here how after consolidation, VTD resulted in 37-40% of minimal residual disease negative. So definitely the addition of daratumumab improved and upgraded also the quality of the response. And the probability of achieving MRD negativity with the DARA VTD was sustained across the different subgroup of patients. And I decided to remark here patients with ISS3 and patients with high-risk cytogenetic abnormalities, because you have to know how important is patients with high risk achieve MRD negativity, because this achievement is going to be able to overcome the poor prognosis of the presence of high-risk cytogenetic abnormalities. The deepest the response, the better the progression-free survival. And here you can see how when patients achieve MRD negative by flow cytometry or next generation sequencing, the outcome is much more better And in fact, the progression-free survival for these patients is excellent, although it's true that the follow-up is of approximately 1.5 years. This is the progression-free survival from the first randomization. This is not the primary endpoint. The follow-up is 1.5 years, but there is a significant benefit for the addition of daratumumab as part of the induction, as part of the consolidation, and maybe also as part of the maintenance, as we are going to see later on. And the hazard ratio for progression-free survival is 0.47, but the magnitude of the benefit and the difference is evident and will be even better with longer follow-up. The benefit or the superiority in terms of progression-free survival, again, is sustained across the different subgroup of patients, including those patients with ISS3, as well as patients with high-risk cytogenetic abnormalities. And this is the overall survival that is immature yet because the very short follow-up, but the curves started to separate in spite of the short follow-up, and definitely we have to wait how these data evolve over time. In terms of safety profile, we can't forget that we were dealing with young, newly diagnosed myeloma patients, and really the addition of daratumumab as part of the induction and as part of the consolidation resulted in no more hematological or non-hematological adverse events, a slightly higher frequency of neutropenia grade 3-4, as well as thrombocytopenia, no more peripheral neuropathy, no more gastrointestinal toxicity. And in fact, when we evaluate other common adverse events that we usually see when we treat our patients with daratumumab, like infections, you can see here how in the Cassiopeia study, the rate of infections was comparable. Infusion-related reactions is the only adverse event specifically allocated in the DARA arm, but it is observed in 35% of the patients, only 4% grade 3-4, and you have to know that with the subcutaneous formulation, these infusion-related reactions decreased and will decrease in a significant manner. What is the impact of daratumumab in the peripheral blood stem cell collection? In principle, there is not any problem. You can see here how patients were able to collect 6 million of CD34 cells and almost 9 million in VTD. So CD34 cells enough in order to do 1, 2, or even 3 autologous stem cell transplantation. And in fact, the proportion of patients who finally received the autologous stem cell transplantation was over 90% in both arms. This data supported clearly the approval of VTD plus daratumumab as a new standard of care in this population, approved by FDA, European Medicines Agency, many other authorities, and as I previously told you, the European guidelines recognized DARA VTD as a standard of care. What about the quality of life? I told you at the beginning that within the main objectives we can plan for this population, in addition to prolong the overall survival and the progression-free survival, we have to try to maintain the quality of life of our patients. And in the Cassiopeia study, overall, this is the global health status score reported by patients, and you can see how this global health status reported by patient was slightly better for DARA VTD versus VTD. But when some specific domains were evaluated, like the cognitive function as well as the emotional function, you can see how this difference is statistically significant post-consolidation. And the same is applicable to an important domain, that is the pain, something that clearly impacted the quality of life with the patients, and patients improved pain, significantly improved post-induction, but this benefit was much more evident at the end of consolidation. In addition, just one additional comment, you know that the diagnostic criteria for myeloma updated in 2014, and it is possible now to do the diagnosis of multiple myeloma to patients without any grave symptomatology. This is the subgroup of patients included here with a SLIM criteria. So just with any one or more of the biomarkers you know, more than 60% of plasma cell bone marrow infiltration, serum free light chain ratio higher than 100, or more than one focal lesion in MRI. And in the Cassiopeia study, they separated this subgroup of patients included just with slim criteria without CRAB symptomatology. And overall, in slim only and in patients with CRAB, DVTD was always superior to VTD. But when we compare the DVTD slim only and DVTD CRAB criteria, it seems that the complete response rate as well as the probability of achieving MRD negativity was higher for these patients included without any CRAB symptomatology, and the benefit in terms of progression-free survival is not observed yet in a clear way, definitely because of the short follow-up, but it would be interesting to see if the outcome for this patient would be even better, and this would put in context how the early detection and the early intervention finally will result in a benefit even in terms of outcome. Just before finishing my presentation, let me discuss with you some important issues that have been addressed at ASH 2020. And one of them is if it is possible to serve autologous stem cell transplantation at relapse, because sometimes we have to consider the patient preferences, or we have to consider the risk status, or even the minimal residual disease evaluation. But the data we have today are coming, point number one, from this French study in which 750 newly diagnosed myeloma patients were included, receiving 3 induction cycles with RVD, followed or not by autologous stem cell transplantation. So transplant was compared with consolidation with 5 cycles of RVD, and all patients received maintenance with lenalidomide for 1 year. And probably you know how transplant was superior in terms of progression-free survival, and this was the primary endpoint, but after a very long follow-up, approximately 90 months, no significant benefits were observed in terms of overall survival. Important point to consider, approximately 90% of the patients who did not receive a transplant in the upfront setting, they received it at the moment of the relapse, and maybe this can explain the lack of difference in terms of overall survival. We have another clinical study conducted by the European Myeloma Network, and including also over 1,000 newly diagnosed myeloma patients. And again, transplant was compared, in this case, with consolidation with bortezomib, melphalan, and prednisone after induction with Cy/Bor-D. And when the role of transplant was evaluated here, and after also a longer follow-up, transplant was superior in terms of progression-free survival, but also translated into a significant benefit in terms of overall survival. What are the main differences? You had the opportunity to see in the previous slide how the comparator was not RVD, but a VMP, and the induction regime was Cy/Bor-D. And I previously told you how I consider that Cy/Bor-D is maybe suboptimal. But there is another important difference, that in this study, only approximately 1/3 of patients in the VMP arm received the transplant at the moment of the relapse. And this can explain, at least from my point of view, this benefit in overall survival, and especially the lack of benefit in overall survival reported in the French study. And there is one additional study conducted by the Italian myeloma group, the Forte study, evaluating KRD transplant and KRD as consolidation with a KCD transplant, KCD consolidation, and KRD 12 cycles without autologous stem cell transplantation. And when the progression-free survival was evaluated, you can see how the winner was KRD followed by autologous stem cell transplantation. And in the middle, you can see here KRD 12 cycles. And again, in the left part of the slide, you can see how the minimal residual disease negativity rate was significantly higher for patients receiving KRD transplant and KRD as consolidation. In order to try to answer to this question, is it possible to reserve autologous stem cell transplantation at relapse? I would say that today continues being standard of care, and I think that is a complementary strategy rather than alternative to all these novel agents-based combinations, even incorporating the monoclonal antibodies anti-CD38. It's true that the absence of benefit in overall survival makes possible to consider sometimes the patient's preferences, but I think that the next question to be evaluated in prospective clinical trials is not early versus late transplant, but maybe transplant yes or not in some patients. Would it be possible to skip a transplant in some patients? From my personal point of view, maybe standard risk patients receiving optimal inductions, 3 drug-based combination plus monoclonal antibodies, and achieving MRD negativity could potentially skip autologous stem cell transplantation. Next question is about the role of consolidation. And I previously alluded to this, and in fact, in the recommendations, induction, transplant, and maintenance is always observed, but consolidation, we can put a question mark. The European Myeloma Network addressed also the role of consolidation in the same clinical trial in which transplant has just been evaluated, because patients were randomized again to receive consolidation with RVD versus no consolidation. Definitely consolidation with RVD improved the quality of the response and translated into a significant benefit in terms of progression-free survival in both arms, VMP or autologous stem cell transplantation. However, I would like to pay your attention to the forest plot you can see in the right part of the slides, because when we evaluated the benefit in patients achieving stringent complete response or complete response after transplant or VMP, and definitely before consolidation, you can see here how the benefit for BRD is not so evident and in fact crosses the number 1. What is my conclusion coming from this analysis? That together with the stamina trial, in which you probably know that no significant benefit was observed for consolidation with RVD versus second consolidation with a second autologous stem cell transplantation versus no consolidation, maybe from my personal point of view, is that if after transplant you consider that you are going to be able to upgrade the quality of the response, go to consolidation. If you consider that your patient has achieved the optimal response, maybe minimal residual disease negative, I would directly go to maintenance and I will not give consolidation to my patients. Around the concept of tandem autologous stem cell transplantation, you probably know that patients with high-risk cytogenetic abnormalities usually benefit from tandem autologous stem cell transplantation, although it's true that this concept has not been evaluated in the situation of 3 drug-based combination plus monoclonal antibodies anti-CD38. And the evidence is coming again from the European Myeloma Network trial, in which you can see here how patients receiving tandem autologous stem cell transplantation experienced the same progression-free survival regardless of the cytogenetic information. How are we going to improve all these results? Definitely, we are going to improve the induction, carfilzomib, lenalidomide, and dexamethasone, evaluated in the Forte study. But definitely, I think that we are going to move to 3 drug-based combination plus monoclonal antibodies. VTD plus daratumumab is today a standard of care, but personally, I consider that RVD plus daratumumab, RVD plus isatuximab will be maybe the new standard of care for these transplant-eligible, newly diagnosed myeloma patients. We will see if we will continue doing transplant to all patients, and the novel options about maintenance are going to be incorporated. In terms of induction with the DARA plus VRD, the Griffin study evaluated this new combination. This is just a phase 2 randomized study, and the addition of daratumumab to VRD significantly increased the complete response rate as well as the minimal residual disease negativity rate. And this was the primary endpoint. So the trial met its primary endpoint. No benefit has been so far reported in terms of outcome, PFS or overall survival, but definitely we have to consider that the sample size was rather small, and we have maybe to wait to to have the results of the phase 3 Perseus study, in which VRT is being compared with the DARA VRT as part of the induction, consolidation, and maintenance. And in this trial, the primary endpoint is progression-free survival. And in terms of maintenance therapy, I previously told you that lenalidomide single-agent continuous therapy is today the standard of care. But fortunately, new options and new possibilities are being incorporated to the maintenance therapy in myeloma. Daratumumab single agent is being evaluated again in the Cassiopeia study, in the second part of this study. We don't have a solid data yet, but in this progression-free survival curve I showed you before, definitely we are observing the impact of daratumumab as monotherapy in this experimental arm receiving DVTD as part of the induction and consolidation. And in fact, a press release announced at the end of last year how DARA monotherapy was able to significantly improve the progression-free survival in comparison with observation. I realized that observation is not anymore the standard of care as maintenance, but it was the situation when the Cassiopeia study was designed. And definitely new combinations are coming, like daratumumab and lenalidomide, and we have a preliminary data coming again from the Griffin study. And when patients completed 1 year of maintenance with DARA plus lenalidomide, the complete response rate was almost 82% versus 60% for patients receiving lenalidomide only and maintenance. And important, this translated in approximately 63% of patients achieving MRD negativity. And you can see here how 40 and 30% of the patients were able to sustain the MRD as negative at 6 and at 12 months. And we will see, but definitely this information is going to be translated into excellent outcome for this specific subgroup of patients. And carfilzomib is also taking part of the maintenance in some experimental approaches, like in the Forte study. And when carfilzomib is added to lenalidomide as maintenance, the progression-free survival is also significantly longer. And again, you can see here how up to almost 50% of the patients were able to convert the MRD positive into negative. So I think that the good situation is that new options of maintenance are being incorporated to the management of this population. And in summary, and I think that this is my last slide, if we focus on the management of transplant-eligible newly diagnosed myeloma patients, don't forget the undetectable measurable residual disease and sustained over time as an important prognostic factor predicting progression-free survival and maybe also overall survival. And try to evaluate this undetectable measurable residual disease if the technology is available. How to manage them? I think that PIs in its plus anti-CD38 monoclonal antibodies and daratumumab is today the reality, are being incorporated as the new standard of care to be utilized as part of the induction and as consolidation after autologous stem cell transplantation. Transplant today remains a standard of care, and maintenance today continues being lenalidomide, but new options are coming. And definitely with all these news, with all these incorporations, I think that in the future we will be able maybe to offer the cure to some newly diagnosed myeloma patients. And I stop it here. Thank you very much for your attention.
Well, thank you very much, Dr. Matthias, for your kind presentation and summary. I don't know, Abdul Wahab, do we have time for questions?
We actually have 1 minute, but we can expand this to a few minutes because we have very valuable guests and we'd like to ask some questions.
Okay.
So let me just start off with the questions for Dr. Bassar. Give Dr. Mateos time to catch her breath. So Dr. Bassar, the first question that popped up in my screen is, what about NK cell exhaustion? Is this going to be a limitation for the CAR NKs or not?
Well, I'm like now we're still working on it. I'm like there's no well-defined like the phenotype for NK cell exhaustion. So first of all, with IL-15, yes, of course there is a risk to be like at the end like they relapse like some of the patient, and when you look at them like the NK cell like phenotype, they are losing them like their function with the high expression CD57 and the KLRG1. But there is not like T cells like PD1, CTLA4, and then now we're trying with different cytokine with some checkpoint inhibitor knockout. We're trying to overcome with the NK cell exhaustion.
Have you encountered any clinical evidence of NK exhaustion in the NK so far?
Well, like for clinical evidence, like the patient that we infuse them like the current cases at the end, like even like 6 months, like 1 year. Just when you look at them in when you look at them like the NK cell phenotype, they're losing their ligand, like the activations, like the receptor, like BNAM, like NKG2D. They're all other like the NCR receptor. Besides that, just like they're losing the ability to produce the perforin enzyme B.
Thank you very much.
Mm-hmm.
So do you want to take any questions, or should we go with the NK?
Dr. Matthias, in patient, with less than 10%, you have around the VRD failure, like they are non-responder. So in your practice for those patients, like, do you add daratumumab, especially if they are like around 67, 65, multiple comorbidities? Maybe VTD base is not a good option for them. So what do you like an option like adding dara, switch to KDD? What's your preference?
Well, this is a good question. Unfortunately, this is not a common situation because with RVD, approximately 90% of the patients are able to achieve a partial response. But it's true that when we face with any patient in this situation, the situation is challenging. And my preference is to switch to KD plus daratumumab because we are going to switch from bortezomib to carfilzomib. We know that carfilzomib is able to overcome the bortezomib resistance, and we are going to add the monoclonal antibody anti-CD38. Another possibility would be to go to Pomdex plus daratumumab, but definitely I will switch. And it's true that we could potentially think about DCEP or conventional chemotherapy, but maybe we are going to add more toxicity, and I am not completely sure if we are going to add more efficacy. And I would reserve this type of conventional chemotherapy like VDT-PACE or just DPACE, because we are not going to incorporate again bortezomib and thalidomide or lenalidomide. Would be my choice for young patients with aggressive disease, maybe with extramedullary disease. But if extramedullary disease is not present, my preference is in my clinic KD plus daratumumab.
Okay.
Very good. Dr. Bassar, for the back to the NK cells, there are actually many interested in these cells to the many questions actually that I've been getting on my cell phone rather than the actual platform that we're using is that how promising is CAR NK for BCMA for multiple myeloma, since we're speaking about multiple myeloma?
Well, I'm still like, yeah, thank you. I'm like this is the one target that our lab is working on it. I'm like again, I'm like with the Takeda, I'm like the collaboration. So we have like the preliminary, like the data in vivo and in vitro, and it's looking quite similar. We can eliminate the myeloma. It's like can cure like the some like the mice with the anti-BCMA CAR actually. So hopefully, I'm like in a couple of months, I think it's like they're gonna start like the phase 1 trial for this. And we have actually just to add that, I'm like besides of BCMA forums like the multiple myeloma, we have like other target, single target or combination with like the other like BCMA with CD38 or with CCS1 or like CD138. I think in early next year, we're going to start clinical trial with that.
Very good. Thank you very much. So the fact that you, in the Liu et al., the famous publication by your group, that you guys haven't reached the max dose for the CAR NK cells. Is this something that should provide hope that we can go up and up in the dose to get more response?
Yes, definitely. So just like there is the main issue with the NK cells, as I mentioned, like in our slide also, there was like about the persistency. But when you put them, like even if you look at them, like the table that I summarized them, like the results from the clinical trial from 11 patients, even with like the low number of cells, we're getting them like the really high response, actually like the complete response. And we didn't see even like the one single like the patient any neurotoxicity or cytotoxicity, because our concern, since we incorporated our cases with IL-15, we thought IL-15 can be like the toxic. But in the safety like the study, we saw that, so that there is no any toxicity like regarding the current NK cell infusion. Now we start to like up like the going up. And actually, like for some patients, like instead of like the single infusion, we're going to like for second or maybe third infusion. It depends on like the patient response. Yeah, like I think it's going to be really promising. Like in the future.
So do you have any questions for Dr. Mateos?
Problem, I cannot. I don't have an access to the question platform, so I don't know if any other.
Okay, Dr. Mateos, you know, everybody talks about MRD and multiple myeloma. Do you think the technical no, I wouldn't call it issues, but MRD standardization would be a problem in using MRD-directed therapies or approaches?
Well, I think that standardization is not going to be a problem because, well, next generation sequencing is an automatized technique, and next generation flow is becoming also an automatized technique. It's true that the next generation flow requires from observer expertise, and in fact, I think that both techniques had advantages and disadvantages. The authorities are now in the process of evaluating the role of MRD in myeloma as a primary endpoint in the upcoming clinical trials. And in principle, they would prefer next generation sequencing, especially because of the standardization or because there is much more objectivity in the evaluation. But it's true that both techniques are feasible. And the next step, of course, is to incorporate the minimal residual disease status into the treatment algorithm. And there are many clinical trials going on in which this is what it is happening, because now the treatment for patients with multiple myeloma is in principle anti-progressive disease. But this is not very feasible, especially for young patients, 50-year-old, and to say to these patients that they have to be on treatment forever. Maybe we can incorporate the minimal residual disease negativity and sustain it for, I don't know if 1 year or a couple of years, maybe, in order to plan stop therapy. And the same is applicable even to the autologous stem cell transplantation. Standard risk patients receiving optimal inductions and achieving MRD negativity sustained over time, maybe we can potentially skip transplant. This is ongoing, and maybe we need some additional years in order to make a reality the utilization of MRD in the routine, in the clinical practice, and more important, to take therapeutic decisions based on the results.
Very good. Thank you very much. So do you have any more questions, or should we just conclude the session?
Just a question about like outside the clinical trial. Is it like are you using data in a quadruple in Spain, like outside the clinical trial? I know it's an EMA approved, but are you really using it?
Well, you know that after the European approval, negotiation for the reimbursement price has to be done in all European countries, with the exception of Germany. So in Spain, we can utilize right now daratumumab in the transplant ineligible population, because this is the combination so far reimbursed, and we can't utilize outside of clinical trials daratumumab in the transplant eligible population. It's true that if we have a special patient in which we consider that he or she is going to obtain a significant benefit, we can ask for DARA plus VRD in some specific patients. And as the combination has been approved by the European Medicine Agency, sometimes this combination is approved.
Thank you.
Okay, we can go on for hours with these really thought-provoking topics. Thank you very much, Dr. Bassard, Dr. Mateos, and thank you to the 3,600 attendees today. We look forward to hear more about the NK news. We're eager to get an off-shelf CAR therapy, as well as we were eager to see myeloma cured. So hopefully in the near future. Thank you very much.
Maybe we have to combine CAR T or CAR NK in order to cure myeloma.
Sure. Yeah. Why not? I mean, that's you have to be innovative. Absolutely. Okay. Thank you very much. I think this with this we'll conclude our session for today and the whole conference for today. Thank you very much, and you have a good night and good evening for those in Europe and Houston. Thank you very much.
Thank you.
Thank you. Bye.
Okay.
Thank you.